slightly different order because that wasn't appropriate to be live streamed. So we'll go to item 1, please, which before we start, I should say usual etiquette, please. So mute, please, when you're not speaking. And if you've got a question, raise your hand. If you don't have a raise your hand button, please just wave or put a comment in the box and I'll try and pick that up. So apologies for absence. Jenny, I think we've just got Michelle Hughes. Is that right?
Yes, that's correct.
Okay, declarations of interest. You've got the paper with the changes on it. Mike Cook, I know that you've notified some changes to Jenny, so we'll pick those up next month. Thank you for letting Jenny know. If there are any other changes, please let Jenny know. And if there are any items on the agenda where you need to declare an interest, please do so and then remove yourself from discussions on that item. So item 3 is minutes of the meeting held on the 29th of July. You've all had them. Are there any points of accuracy that you've not already let Jenny know? No. Any matters arising that are not on the action log? No. OK, we'll take those as a true record. Thank you. We'll approve those. So if we can move to item 4, which is the action log and matters arising. Any questions on those? No, I'm just scrolling down. No, I think quite a few of those items have been closed off. OK, any comments? No. OK. Well, in that case, if the board members don't mind, if we could chop around, I'm afraid, because Jennifer is joining us for the first time at the board for her annual report on Guardian of Safe Working, which is item 18. And Jennifer's got clinics later. So if you don't mind, if we could just move item 18 up the agenda. Francis, if you could do your usual magic and tell us the page number, that would be helpful. So, Jennifer, it is lovely to see you at the board. Welcome to the board. I know you've been going to the subcommittees, but lovely to see you at the board, and thank you very much for your report.
Page
John,
144, Sharon.
Page what, sorry?
144.
144, please. John, do you want to introduce this?
Sorry, just the mute button. So, good morning, Jennifer. So, every trust has to have a guardian of safe working appointed in the trust. It's an independent post. We're very fortunate to have Jennifer, one of our own, in the post, and she took over from Lucy Williamson last year. So this is the presentation of the report. Just for clarity, Jennifer does work independently of me, the medical director. I do offer support and guidance, but it's very important that we just to clarify the independence of Jennifer's role. So, Jennifer, would you like to give us some brief highlights on the report, which we'll have all read and gone through, and I suppose just giving a sense of what's going well and what the next steps are in terms of development?
Okay, good morning, everyone. As John said, I'm Jenny. I'm a doctor who works in the trust and has taken over the Guardian of Safe Working role. So, for the last year, we changed the work schedules last August, and overall I think the highlights are that seems to have been a massive success, that we've had a significant reduction in the amount of exception reports put in by junior doctors, and the exception reports are put in when junior doctors end up working in excess of the hours they're expected to work. So by adjusting the work schedules, we've significantly reduced that, with some months no exception reports going in at all, which is obviously really good news. I also think it's really important to highlight that we've got very few gaps in our rota, which does reflect some of the national trends, that we are having better recruitment to psychiatric training posts. But I think we're doing particularly well in that area because we've not actually reduced our numbers, which nationally seems to have been a bit of a trend, that they've got 100% greater percentage of recruitment by reducing the number of posts, which we haven't had to do. So that's really good news. So the only thing kind of in terms of sort of the recommendation I made is sort of going forwards. We just need to continue the work that is already ongoing with regards to providing adequate rest facilities for junior doctors on call. Okay, so it was a bit short and sweet, but yes, any questions? I see.
No, that's fine. Thank you, Jennifer. And I have to say, a really comprehensive, really good report, I have to say. Enjoyed reading it. It was absolutely comprehensive. So I'll go to Francis first. Your question, please.
Thanks, Sharon. And as you say, really good, really comprehensive report. 3 minor points. One, well done on the tenfold reduction. That's really impressive indeed. Secondly, have you got any idea when the work might be done on the facilities? Because obviously it's something the junior doctors are after. So I was just wondering if you had any idea of when. And my third question, so you've got the second question rather, you've got them all. You talk about the fact that they prefer the 3-4 on-call pattern, but it's against TCS regulations. I presume that's okay that we break those regulations if our doctors are happy. That's my comment.
So yeah, just take the last one first. Yes, it is okay as long as it's done by local agreement, which it is, and our juniors prefer that. So that has been okayed by the BMA and is reviewed regularly at the LNC, the meetings with the juniors. In terms of the rest facilities, I think that is kind of I think it's ongoing, and I'm hoping that it won't be too long before we get that. I think COVID, like a lot of things, I think COVID kind of halted some of the work on that, but I think that is now kind of up and running again, as I understand it.
Okay, thank you, Steve, and then Michelle.
Thanks, Sharon. I'm really just to echo, I think Francis has said, just to congratulate Jenny on the work that's done. We get regular updates on this at the Workforce Committee, but I think it is a fantastic achievement to get it from, excuse me, 150 down to 10. So it seems to be working really well. Really good report. So thanks very much.
Thanks, Steve. Michelle.
No, I'm going to just echo thanks, and I do dial in very regularly to meet the junior doctors as well. So I do know there's lots of really good work going on, and I know that they're are really settled in what they're doing. That's thanks to Jenny, and it's really good that we've got no exceptions. I was just wondering if Pete wanted just to give you a bit more. Sorry, Pete, just a bit more of an update on where we're up to with the capital, because you're right that it has stopped a little bit with COVID. We are going to do a wider communications on our capital plan, because I think sometimes it does get lost in amongst everything else that we're doing, but we are actively progressing quite a lot of work on capital. But Pete, do you want to just give us some headlines, if that's okay?
Yeah, I mean, specific for junior doctors accommodation, Michelle, we've got 60,000 of funding ring fenced. I think John's been engaging with junior doctors about ideas about how we can utilise that funding. And I guess I would say today we've still got the commitment for that funding to be utilised in the best way possible. I think we do have some constraints on the physical estate, so we would maybe look at alternative options, but from an assurance point of view, for me, that funding is ring fenced in our capital programme and will be utilised to improve junior doctor accommodation. I don't know if John wants to add anything.
You're on mute, John.
So just a couple of things. Pete, in fairness, you've been really upfront and helpful, as has Rob and the rest of the team, that this will be done. And unfortunately, it was interfered with by COVID. One of the reasons we got the 60,000 funding was that actually we have a very credible reputation with the BMA and the support of our junior doctors. So that's a really good example of where a trust and its staff can work together. And your explicit intent there is welcomed in the public forum, but that's nothing you haven't been saying privately for a long time. Interestingly, I have had conversations with the juniors, and it's almost like a bit of a Christmas box. You don't know which Christmas present to open first. So we are actively trying to persuade them to say, look, what is the best way to invest this money in the short term and the medium term to improve their experience? But just as importantly, we need to remember as we move forward with the campus project, how we think about what the future looks like in terms of facilities. And I know that's something that the campus group will be focusing on as well. So the juniors know it's there and ready. We're willing and able to help, but it's just about finding the right way to use it in the time and space. And we're grateful for Jennifer's support with that.
Thank you. Any further questions for Jennifer? No, Jennifer, can I say, as I say again, fantastic report, really comprehensive, really easy to follow, and of course, lots of good progress in it. So thank you very much. And thank you very much for coming to the board. And we look forward to seeing you in the subcommittees and next time we come to the board as well. So thank you for joining us this morning.
Thank you. Just before I go, can I just say also thank you to the junior doctors, because it was their work that highlighted how we needed to alter the work schedule, and that was a lot of hard work put in by our junior doctors. So I want to reflect that thanks back on them.
No, that's great. And if you wouldn't mind passing on the board thanks to them for all the time they put into that, because as you say, it does need reflecting and acknowledging. So please pass on the board's thanks to them as well. So thank you very much, Jennifer.
Okay, thank you.
Okay. Thank you. If we can move then to item 6, which is my chair's report. I'm delighted to let you know that we've got a new appointed governor for East Riding of Yorkshire Council. It's going to be Paul Nickerson, and Paul will be joining us shortly, and we've already got meetings arranged with myself and Michelle to meet with Paul, and I'm sure he'll meet you all, those of you who don't know him, in due course. So that's really good news. I've continued to meet with the staff governors and the public governors, and Lynn joined me for the last staff governor meeting as chair of Health and Wellbeing Board, because the staff governors obviously have a very keen interest in staff health and wellbeing, and that was a really good meeting that we had with Lynn. And I've met with the public governors as well and individual governors. And hopefully you'll start to see that the governor elections are underway. We've got 10 seats out for election this year, so it's a really big year for governor elections. So please do, promote that wherever you can and encourage people to stand for election to our Council of Governors. In terms of stakeholders, I've met with Vanessa Walker, who's the new chair of the Health and Wellbeing Board, and Michelle picks up that in some of her report. And yesterday, a few of the board, we had a meeting with the chair of CQC, which was a really positive meeting with him. To tell him a bit about the trust, but also hear about future plans for the CQC. So I think that's it for me for this month, unless anybody's got any questions. No, thank you. If we can move on then to item 7, Michelle, your Chief Executive report, please.
Yeah, good morning. Thanks, Chair. It's obviously there for people who have had a look at it. I'll just pull out a couple of things as usual. Obviously, you mentioned staff health and wellbeing, Chair, and that is obviously essential to what we're doing. If we've made a real solid continuum on staff health and wellbeing as well, alongside patient safety. And we continue to use the apps such as Shiny Minds, which I've mentioned in my report, and we've done a bit of what we call a ripple message, and we're very fortunate as an organisation, and I thank the team involved really, that we're actually one of the national pilot sites for things like the ripple message, but we're also going to have more of a golden button as well, which is where that we can thank staff and support staff, but more on that probably next month. But that is a really good app, and I'm really pleased to know that more staff are downloading it, and I would strongly recommend that people continue to do that. And obviously with the forefront of what we're doing, especially as we go into what's going to be a challenging winter. Lanyards and badges have gone out. I think we've mentioned that along the way. So being very positively received by staff, especially the little thank you badges that we sent out to say thank you for the initial work up to date in the pandemic and just general work that people do. I think what's really interesting is that the research and the conference speakers, so it really proves just how much we are really developing as an organisation in the research and that international field as well. So the information's there, but I certainly thank the research team who are constantly striving to increase our strength in the research field. And obviously the research conference is coming up, which I think we're all looking forward to. I go on to mention the ICS, which is developing really strongly at the moment with 2 subsystems, which is actually causing quite a lot of extra capacity work for the staff across the organisation, including the executive team, as you can imagine, because where we're placed, we're involved in all the system work. So in the Humber sector, which includes the South Bank and then the North Yorkshire and New York, and it is developing at pace. What is really important, which I put it in my report, is the work around the principles and the clinical principles, which I think are really important, and it's really good that we've got them. I won't read them out, they're there in front of you, but we're going to try and mould all the work that we do in the ICS along those clinical principles. I've mentioned in there about the Staff Resilience Hub. I'm hoping to give you a bit more of an update next time on that, but that is developing at pace. We are looking to have 1 staff resilience hub across Humber, Coast and Vale, which is really great that we've got to that position, but I will update you next month on that. BAME network has taken place in the integrated care system, and that's linking into our own BAME network as well, which Grace is spearheading fantastically, and that's really galvanising and taking off the work across the organisation. I do continue to dial into various team meetings and all the team meetings, so regularly link into huge amounts of staff. And I haven't put in the report, but I did have a Meet Michelle session during the month, which I think was about 96 members of staff joined, and that was a really great informal, as much as you can, on Microsoft Teams conversation. Morale's still high, but staff are getting tired, as we would imagine, which is why we're constantly saying that staff must have breaks, and we are conscious of that. Planning for a very bad winter, which we'll come on to, but I will stop there, Chair, and I'll be asked any questions, I'm sure, as we go through.
Thank you very much, Michelle. Mike Cook.
Good morning. Thanks for the report, Michelle. And can I just say thanks to all the team for putting out some really good board papers today for all the meetings we've got. It's a really good set, and I think comparing it to maybe a few years ago, it provides a lot of insight and assurance. 4 things, if I may. Under 1.6, just to reinforce Michelle's view on research, again, delighted to see more and wider ongoing collaboration. It's a collaborative endeavour, just the sort of thing that helps relationships as we see the Humber Coast Vale system mature. Under 4.14, I was delighted to see 17 peer support workers have been appointed. It'd be great to see if we could do something in specialist services. I was really quite taken with our earlier presentation, so that can be done. So well done to Derek and the team for progressing that, and Lynn's support. Also, really pleased to see that we're doing an autism strategy under 4.22. Very happy to have a look at that if that would help anybody. And I just want to mention under 6, Michelle, the team, Rachel and Adam and everybody on Unbelievable, and all of that, and the brand has really gone places during the last 6 months, and I think we just need to say well done to people. So all positive stuff, and thanks for all that you're doing.
Thanks, Mike. Francis.
Thanks, Sharon. A fair few things just to say well done and pick up on. I agree with Mike. Papers are really, really good. Really good to see the guest speaker we got for the international conference. Really good news, and like Mike, the research. It's really good to see what we're up to with that. Under 2.2, I was just wondering about the Scarborough review and what exactly is going on there.
Okay, do you want me to pick that up now, Francis? For a while, we've been saying that Scarborough shouldn't be an entity in itself, that it links into the Bridlington work, the Whitby, etc. So now we've agreed as a geographical partnership, also as an integrated care system, that we'll do an East Coast strategy. So the focus of that will be obviously Scarborough Hospital, but it will then encompass the wider geographical patch. So that work is ongoing. There has been a director appointed. It's Simon Cox who's going to lead that on behalf of the North Yorkshire system. So we are expecting the work to start to progress, and I think it's really important. I've been pushing for the fact that it's not just about the hospital. We have to link in the out of hospital work and the developments that we're doing at Whitby and the developments that we want to do and we aspire to do at Bridlington. So at last now we're doing that, and we're taking it. I'm waiting for the project proposals to come from Simon, and when they do, we'll share them in the organisation.
Thanks, Michelle. My next one was on 2.3, which was, again, really good news. And I just wondered, because there's so much, and you talk about primary care placements, how that might impact on our primary care strategy and surgeries, having all these extra bodies. Don't know who was best placed to pick that up.
I can pick that up, actually. So we've just appointed a GP education lead as of yesterday, who will be taking up the role. So the idea is that we can support the university with increased numbers of sort of primary care students, but just as importantly, we know it'll lead to a quality improvement piece within our own surgeries, because those surgeries which tend to have students in them, whether they're medical or nursing, tend to have a little bit more going on in terms of curiosity. So I think it's actually a good opportunity for our services. It'll be good for our patients. It'll be good for the students who come to us, and if we can facilitate the university at the same time, I think it's a win-win.
No, I'm with you, John. It's a potential source of future GPs, hopefully, for us going forward.
Yeah, it is.
Under 4.1.4, like Mike, really impressed on the peer support stuff. I remember the presentation we had with 2 of our existing peer workers, and it's really good to see that flowing through. So I'd echo what Mike has said. John picked up on this at the start. I don't know if Hilary was on, but well done on the white ribbon campaign. Really good to see that. So really impressed that we're doing that. One for John under 4.3.3, just out of interest. How do you run this Murder in Mind event with 500 people? I mean, it's great to have that number on it, but how does it work?
Well, I'd love to say we were doing it at the door and we were charging them for the pleasure, but it's all going to be run online. And we are using a professional company to do this because it's a complex piece of work. So it's almost like a piece of in-house broadcasting that we're doing. Very exciting. But we will have 500 people, if not more, by the time we get it going. So fingers crossed that the broadband works and nothing falls over. But we're really looking forward to this, Francis.
Another great shop window as well, John, to get that number of people from presumably all around the country.
Yeah, from everywhere, and you know, we'll be using it as an opportunity to promote the positive role of psychiatry in health, positive role of people working in psychiatry, and then the last but not least, the role that Humber has in our place and in our system, but actually being a great place to come and work and to learn.
Excellent. And then 4.4.4 for Steve, again, really good to see that the leadership program is back up and running. Is that going to be in person or virtual, Steve?
It's in person.
So Francis, it's in person. So we've so we've socially distanced and done all the risk assessment, and it's up and running in the lecture theatre. So I think it's still not ideal because obviously the social distancing, but it's far better than doing it over Teams. And the feedback we've actually had an intake on Monday, Tuesday this week, and the feedback we've had has been really positive. So
it would be nice if we could have the dates, and then if we are allowed, I'm not sure whether we are or not, it'd be nice to come and sit in at a socially distanced distance.
I'd love to say, yeah, but we can't. We're maxed out in the lecture theatre. It's not we don't want anybody there, but we are absolutely. Because I went in to say hello and somebody had to come out. So one of the facilitators had to come out. So because we'd measured it down to the nth degree, as you can imagine, Francis, especially at the moment with the COVID situation rising, etc. So we've had quite a bit of thought about, and it's a bit like the Murder in Mind doing it in the lecture theatre. We've had a long conversation with Stella and the production team about how they can do that and maintain the distance as well. So even though I would love to say please pop in and sit down, it's really difficult. I think if you know, if we really need to let's structure it, but somebody will have to come out because I only was in 5 minutes just to say hello, but somebody had to come out and allow me to do that because it's just the right size for the numbers we've got. I don't want to. It's only about 12 or 13, Francis, and they've got to be behind a desk and what have you, and wear masks and re-up the doors and everything. So it's really quite strictly controlled.
No,
and I'm still liking it. So that's good.
No, it's just that if we could have done support, but I don't want to interrupt anything that's going on. So fine. And then the final one was just to say, because we haven't met officially since, really well done on the annual members meeting. I thought it was excellent. Yes, I thought it was really professional. You all came across really, really well. I thought it was an excellent event. So well done to everyone.
Thanks, Francis. Sorry, I did actually write that down just to raise, but thank you for that. Thanks to the production team, and I will just make one final comment at the end about comms if I can, Chair.
Of course you can. Yeah, that's fine. Sorry, I should have mentioned that as well, but thank you for the feedback, Francis. Peter Barron, you had your hand up and it's gone down now. Has someone else asked your question?
No.
Okay, go ahead.
I don't know why it's gone down, but can I ask well, it's sort of one question and 1 point really, if I may ask, just about the flu jabs. I know we want to do 95%. But I guess with everybody being so dispersed around Hull and East Riding and even beyond that, really, what is the assurance and the sort of monitoring of that that's going to be taking place this year that's going to push us from 75% up to 95%, and given the extra difficulties that it's going to be for people to get perhaps to some of those clinics, quite a drive for some of the people to go to those clinics that have been earmarked. How realistic is the 95%, and is there a contingency plan?
Do you want me to take that, Sharon?
Yes, please, Dave.
Yeah, thanks, Peter. So, and you're right, it's going to be a challenge. I think the key difference that we've got this year to what we've had previously is the number of people that have come forward, which is fantastic because these are volunteers to be peer vaccinators. So we're looking at, hopefully we're going to have, I'm looking at Lynn, probably around about 70 to 80 people across the whole of the patch who will be trained to be able to provide the flu vaccine. So we're kind of going out to them rather than asking them to come to us in a more limited way, which is primarily what we've done in previous years, which has obviously still been successful, achieving 75%. But to get that extra push, it's peer vaccinators that we're going to try and rely on. So the take-up's been great. People are going through their training. It's quite a rigorous process to be able to be signed off to be able to provide the vaccine. Those numbers build all the time. We've got the vaccines delivered this week. So, hey, we're cautiously optimistic, Peter, that we're going to get as close as we can to that, as certainly the mood in the organisation feels quite positive and people wanting to take it forward, which is great. And I have to say, the work that John and Hilary have done, particularly over the years in helping to promote flu in the way that we've done, I think we're really reaping the benefits of that now.
I think just to add that one of the things we have done, Peter, is we've got a gold command meeting on a Thursday for COVID. We've also incorporated that now for the winter planning, and part of that is flu. So we'll be receiving weekly the figures on the numbers vaccinated, so we can keep a real look at it and watch right from day one. So even a couple of weeks ago, we were assessing the peer vaccinators and how we've trained them and how many we've got in place and where they are. And I think there's a lot more awareness about the flu obviously this year, so I think there'll be a lot more staff coming forward. So we set ourselves a hard target, and I think that's really justifiable. I'd like it to be 100%, but you've got to take into account people on maternity leave, etc., etc. One of the things, and again I will say something at the end about communications, but the comms team are doing is putting a film together, and we've actually contracted that out with a cartoon type animation type company. So we want it to be hard hitting but quite fun as well. And I've just seen the storyboards of that, so that should be quite good as well. So, and staff side usually do a little bit of a video with us as well to say the importance of it. So we're trying to do loads of different media, social media type thing, and we'll continue to do that as we go through. But we will monitor the figures on a weekly basis at the exec team meeting on a Thursday.
Okay, thanks very much. Can I just mention one more thing? It's not in the report actually, but I thought I'd mention that I tuned into a couple of the events last week on Dementia Awareness Week, and they were really great. But I thought I'd just mention it now because I think those the videos of those are still online, I think on LinkedIn and Twitter. So if anybody's missed them, I think there's quite a lot of learning there. I think I was particularly interested in some of the dementia sort of themselves talking about the difficulties that they have in the environment that they're in at the moment with COVID, etc., dealing with a more digital world. So if you haven't seen some of those videos, I think that, one or two of them are perhaps worth looking at, and I think there is some learning from those in terms of how we scope some of our services.
Thanks, Peter. John, was it on the flu jab or was it a different question? Because I've got Dean, who's been waiting a while. Just on the flu jab. Yeah, just to say that, Pete, I think it's a fair challenge. I think there's a logistical challenge when you have 2,500, 3,000 staff over 80 sites, but it's also a cultural challenge. And persuading people is the right thing to do. And I have to say, the one thing I think we've cracked as an organisation over the last 3 to 4 years is that this is the cultural challenge of being the right thing to do. And once we get our logistics right this year, I'm pretty sure that we'll easily get past the 75% and aspire hopefully to get much higher than that. Thanks, John. And Lynn will know the staff governors. We had a good discussion about this, Lynn, didn't we, with our meeting with the staff governors and the availability of the jab and the peer vaccinators. So they're very supportive of the whole thing. And you'll have seen it's gone out in the global that obviously frontline staff come first, but there are time slots for when you can book, depending on what role you've got. So board members, please do book yourselves in if you haven't done it elsewhere for your flu jabs as well. Dean, you've been waiting very patiently.
Yeah, thanks very much, Sharon. Just to echo the points that Mike and Francis have made just about the update and the papers, and just great to see positive things happen strategically in terms of our imperatives, despite all the stuff with COVID and some of the innovative stuff that's happening. For example, like Murder in Mind, I think it's really great to see. Just a question about the white ribbon. Like Francis, I think it's great, really good initiative. Good to support it. I see that John's now put his screensaver up as well, drawing attention to the white ribbon campaign. But I just wondered if we had a rough idea of the timescale for accreditation. It was development of an action plan and some work to do, but just what the timeframes might be.
Hilary, do you want to answer that?
Yes, I'm happy to take that. The team are working on the action plan now with the support from the White Ribbon campaign. So I would like to think that we've got the accreditation within the next 6 months.
Right. Thank you.
Thanks, Dean. Anything else before I come back to Michelle? No, Michelle, you wanted to mention about communication?
Yeah, thank you. I just wanted to say a bit, and I'm not going to embarrass Adam, but I might do, just to say thank you very much to the communication teams, really, because I think as we've already heard today, the amount of work that the communication team are getting through at the moment is phenomenal. And we all know that the communication is key to any successful support for staff, etc. But just to mention a few, please have a look at the website if you've not done that. We've done that in-house. And in the main, Adam has done that in-house, and I think, you know, if you go to external contractors, we couldn't have got any better. It is so easy to manoeuvre, and we've already had some really good comments on that. So that's just one. We've got the branding work going, we've got the revised communications internally, which makes it a lot more easy to spot what different communications mean for staff, the different colour collective. It's really simple. We've got all the visual work that we do now, because if you remember, we wanted to keep things as visual as possible. So we've got all that. We've really got I think a culture now of doing things visually if we can, and obviously the presentation at the AMM was in keeping with that. But obviously we've got the flu work coming up, we've got the Together We Can work that's put out, and obviously there's the Unbelievable, which really, we've got such fantastic support, and that's on top of all the posters that we've done in relationship to Back to Basics. So I know sometimes we always have, because sometimes communications are really difficult, because they, you know, we can always say, well, if we did this, we did that, but we can always do things better, we can always do things in a slightly different way. But the communication teams are always working, and I will save some things. There's another couple of quite exciting things coming up, which we'll announce next month. But can I just say personally, on behalf of myself and hopefully the board, just a big thank you to the work that they are doing, because it is having a measurable effect on the organisation.
Thank you, Michelle. I know everybody's nodding or clapping or definitely endorsing your thanks to the communications team. It is amazing, the transformation that's taken place and the amount of work. So yes, definitely thank you to them. So we are asked to, if Michelle Hughes was here, she would remind me that we're asked to ratify one policy. So that is the remote working policy, which is on page 37 of the papers, which has obviously been to the Workforce Committee. Are we happy to ratify that policy? Yes, great, thank you. Okay, if we can move on to item 8, the publications and highlight report, Michelle.
Yeah, I'll keep it short, Chair. This is the national information that comes out. We've got little bits of updates from the relevant lead directors, and I'll just leave it to the board if they've got any questions.
Great, thank you, Michelle. Any questions on the publications report? No. Okay, thank you. It's a good report. If we can move on to item 10, the finance report, Pete.
Thank you, Chair. So this is the performance report as at the end of August. Obviously, it's in the format we're all familiar with. So I think if I just take it as read and move straight to questions.
So any questions on the performance report? Sorry, it is the performance report, Pete, not the finance report. Any questions on the performance report? Yeah, Mike Cook.
It's just one, and it's around the out of area treatments, which is raised. I think we had 22. I wonder if Lynn can just tell us a bit more, or Pete, what's happening and how can we build on that, particularly as we build our profile as lead provider. We need to just contain some of those.
Thanks, Mike. Lynn, are you okay to answer that?
Yes, definitely. So I think it comes up a little bit in the winter plan report later as well. So we have seen an increase in our use of out of area beds. Obviously, prior to COVID, it's one of those areas that we were actually doing very well within. So the primary reason for the rise in the use of those beds is older people's mental health. And you'll see from the performance report is that demand for older people's beds is actually increasing acuity. It's not slowdown of flow through that area. So having looked hard at the sort of number of beds that we've got for our population right now, our view is actually we are in a position where we've got too few older people's beds. So one of the things that we've done on a short-term, sort of medium-term plan, we have got a plan in place. We have secured additional beds too, actually close by there with Navigo. And we are looking at the introduction of some step-down beds locally. We should have those in place for winter. The other thing obviously we're doing is augmenting the older people's acute care pathway, the out of hospital elements and the crisis team. We're actually scoping at the moment the potential use of a day treatment element to that pathway as well, because our view is that that should support us with that older people's bed provision. And we're actually looking at more long-term plans around that with our estates colleagues at the moment as to how we can improve that. We are worried about the out of area position overall. I think it's great that we've managed it so well in the past. I think that's a good platform to work from. But all trust, we've also obviously introduced some COVID safe practice ways of working that has reduced our overall bed base. So we are in a position where we are -7 adult mental health beds because of the COVID safe requirements. So actually the adult beds are actually flowing reasonably well at the moment, but we know all of the trusts are in the same position. So that availability of out of area beds is going to diminish through winter, already probably is. So it makes it all more important that our plans are as robust as they can be. But I can assure you we are looking at this every which way, but our plan is actually to increase the bed base in the manner in which I described for older people's.
Thanks, Lynn. Peter Barron.
Oh, hi, yeah, it's just one quick question from me, just on the dashboard then. I mean, I think it's great to see there's a lot of positive assurance there on the safer staffing dashboard. But there's just one unit I think that's flashing red, and that's New Bridges. And looking at the figures, it's nearly full from this, but yet the registered nurses are quite well down from 100%, and that's probably one of the reasons why it's gone red this month. I just wondered if either now or in the post-meeting note or whatever, we could actually give some assurance on what's going on there in terms of making sure it's safely staffed.
Thanks, Peter. It's a question I was going to ask as well. Hilary, would you like to just give some background to that, please?
Yes, obviously this is July, and it is flagging, so obviously that immediately alerts me to get in touch once I can see the flag. So yeah, there are 2 staff on sick, but they're back at work now. There's also maternity leave and obviously annual leave. This is July and August where we're encouraging people to take leave, and as you've pointed out, a very high use of beds. And so that, coupled with sickness, meant the clinical supervision wasn't achieved. So I've checked that now, and August they've achieved 86%. The staff that are off sick are actually back in work now, so it's been a blip. But obviously I've alerted the matron to it, was keeping an eye on it now, but that's where I've got my updates from as well, from the unit and the matron. So the fact that clinical supervision is 86% for me is an indicator that staff are back in and they're back to where they should be in terms of the performance.
Thank you, Hilary. Francis?
Thank you, Chair. Mike and Peter picked up my 2 main questions. I was just a couple of comments. Just well done on the mandatory training. To carry on and get that level is really good. We discussed it at Workforce, and similarly with the establishment, you know, it's looking good in terms of turnover and vacancies. And again, just well done on the work that is going on there for the team. The other one I was going to pick up on was I know it's only 1 month, but it was good to see that the RTT had started to pick up. Obviously, there's quite a long way to go, but it's good to see that we're starting that, and hopefully we'll see a trend on that. And also that the number of patients waiting 52 weeks for treatment had come down as well. That was, again, a good one to see. So it was just a number of well dones, and the 2 questions I had have been picked up.
Thanks, Francis. Yes, I would have made a comment about RTT if you hadn't, so thank you for that. Dean?
Yeah, thanks very much. It's just a follow-up on Mike's point just about the out-of-area treatments, and thanks for the update, Lynn. Clearly lots of work going on there, but I just was thinking really about whether it's something that's worth sort of escalating, in the sense that, you know, on the back of COVID, around the acute sector nationally, a lot of sort of independent sector space was sort of bought up. And if we're to get sort of, you know, the same sort of parity of esteem around mental health, is whether we should be flagging, given the expected rise that we've got there, the importance of people being within their own communities, is whether they should reasonably be expecting, the purchase of independent and private sector provision that would allow us to keep more people, closer to home. So not for an immediate answer, just maybe something for us to consider through sort of ICS and regional discussions, maybe.
No, thanks, Dane. It's a good point. Anything from anybody else? No, I just got two that haven't been picked up, just positives really. One is the amount of incident reporting, which is high this month and has gone up, but it's of low harm, which is exactly what we're trying to achieve. We were discussing this yesterday in a different meeting, so that's really positive to see that coming through. And the other is just on the dashboard, in terms of Avondale, the very, very low sickness figure. I think it's fantastic. I mean, we always point to them when they're very high, but to have a sickness rate of 1%, I just think that's really, really positive, especially at that time of year and with everything going on. So I just wanted to acknowledge that Avondale's figure is very, very low, which is very positive. So thank you for that. So if we move on now to item 10, which is the finance report, Pete.
Thank you, Chair. So again, this is the finance report as at the end of August. I think it's important just to remind the board that up to month 5, we were still operating under the COVID block arrangements. I think for me, if I pull out some of the key highlights, then we can move to questions. So we recorded a break-even position at month 5 after the application of donated asset depreciation. That's what we're being asked to do. Included in the position was 4.8 million of COVID claims, and that was broken down primarily 3 million of expenditure and 1.8 million in relation to income top-up to bring us back to break-even. I can confirm to the board that month 1 to 4 has been reimbursed, and that cash is in our bank account, and we've had no issues flagged on our month 5 claim, so we should expect that in the bank next month. Obviously, our cash in the bank is high at the moment, and again, that reflects the COVID governance arrangements where we've got an additional month's funding in our bank account, but our underlying cash position sits at 16 million, which is still good for this organisation. I think if I stop there, and I'd be happy to take any questions.
Thank you, Pete, and obviously we've got the assurance report later. Any questions for Pete on the finance report? Mike Smith.
Yeah, Pete, just on the cash balance, I think it's really excellent, fantastic stewardship of that. But I wonder when we're going to have a discussion about investing some of our cash balance and what our strategy might be in terms of cash. It's not something that concerns me and that keeps me awake at night, but I am sort of thinking there may be opportunities for us, and I don't think we've ever sort of discussed what opportunities might come. We sort of look at projects and say, can we finance them? We don't look at the finance and say, what projects can we do?
Yeah, it's a good question, Mike. I guess there's probably 2 elements to answer to that. One, we have a capital control limit imposed on us, so we can only spend up to a certain amount on capital. In the ideal world, I could sit in front of the board or the finance committee and we could have that conversation about spending, but we still operate in a series of capital constraints. I think another conversation, and not for today, but maybe the finance committee, would be what we do with our cash balance and whether we think about maybe investing that. I mean, the market's not great at the moment, is it? 0.1% base rate, but in a different area, we'd maybe been considering short-term deposits to make investment returns.
If I could just follow up on that, Sharon, just a small example we heard this morning. We heard about the Humber Centre and we heard about gym equipment and a radio and things like that. And our instinct as non-execs tends to be, well, that's a little bit on the edge, it's peripheral. How about Charitable Funds Committee? But there is an argument that says, well, there's some small expenditure needed there that's got a real value in terms of patient care. Get on with it.
Shall we have this discussion? Oh, Michelle.
I think in some respects we do that across the organisation, but we don't have, obviously that's not capital, but we do have a capital limit, and I think we do that. I do think we have had a conversation about, and certainly Pete and I have had a conversation about having a cash management strategy, but I think the issue is where other trusts have invested in the past. One, they've been burnt because of either where they've actually invested it, but at the moment, because of the interest rate, there isn't really a lot of return on it. So I do think it's something to start to think about. We'll come on to later. I'd just rather get this next year out of the way with the COVID position, because I'm not saying we might use some of it for that, but we need to, I think, just be realistic a little bit about the position going forward. But it is something that we do have a conversation about, but I think we probably could link that into the finance committee as well. So it's not a bad question, but investment, I think for the time it's going to take us to do that, I don't think there's going to be much return on it, but we'll constantly keep thinking about it, Mike.
Is that okay, Mike? Good question. Okay, thank you. Anything else on the finance report? No, thank you. Can we move on then to item 11, which is the Quality Committee Assurance Report and Minutes? Mike Cook.
Good morning. I'll kick off on the quality assurance piece. I think you can see the Quality Committee on the 5th of August. We looked at clinical supervision in depth, and already Hilary has mentioned that as such an important indicator. And I think Tracy's review right across the organisation is that clinical supervision has moved on, and it's systematic, the numbers are there, and it's a currency of the organisation. We also gained some really good CQC insight, which I think was enhanced yesterday with our meeting with Peter Wyman. Thanks for setting that up, Sharon. To have a developmental visit like that, I think says quite a bit about where we've moved on. In terms of the second major item was on long-term segregation or care away from others, trying to deal in a least restrictive way with individuals with quite complex needs. And we looked individually at 4 cases of the people who were currently in that situation, and we were assured, and Mike Smith may want to say something too on this, but we were looking to see if we were using the least restrictive approaches, and there's a lot of creativity being employed, and it not being used much was the main headline. We also saw the quality improvement programmes, so all 4 areas now have presented quality improvement programmes. They're really improved. I'm delighted to see that in the last 2 years in particular. And I think we got good assurance at this meeting, having scrutinised the clinical audit report, the research and development report, the zero events report, and the safeguarding and infection control annual reports, which are coming today, and they have become real strengths under Hilary's leadership. I think we've benefited a lot, as have our patients and staff, particularly from those 2 during this COVID period. The minutes are there from the 8th of June, and we're meeting next week on the 7th of October. But Hilary and John, my exotic colleagues, would you like to add anything?
Hilary or John? I think you're on mute, Hilary.
It was bound to happen, wasn't it? I think the virtual meetings that we're having are going really well, because we've got quite big agendas, haven't we, Mike? And we cover quite a lot of stuff. But I know when we get to the end, it's, we're in the middle of a global pandemic, and yet we're still managing to get this quality improvement going and keep it going. And I feel quite assured by that, that everybody's still behind that. And I think that's something that I think obviously the non-execs have picked up on that as well, which is good, because we're not just focusing on COVID, but we're also using some of the things we're learning from COVID to enhance best practice as well. So I think it's been really positive. And as Mike says, there's 2 annual reports on today that went to the Quality Committee. And the fact that we've even got an infection control annual report, I think, is amazing, that they've managed to have the time to sit and write that as well with everything else they've been doing.
Thanks, Hilary. John, do you want to add anything?
So I just have 2 thoughts. One, Mike, is about the role of the committee looking inwards, and I think we're able to demonstrate that, certainly around assurance. But I think it's really important to note the fact that the committee is also looking outwards, and we're able to sort of demonstrate that yesterday in the conversation with Peter Wyman from the Care Quality Commission, how we're looking at how the external world is moving on in terms of improvement, and how we're bringing that back into the trust and having meaningful conversations, and actually be able to demonstrate some of the positive change as a result of that, some of which we dealt with in our board story this morning.
Thanks, John. That's really good. Yeah, very comprehensive report as well. Thank you. Hillary's right. You cover an awful lot of ground, so really good to see. Just on the clinical supervision, for those of you who go to the Council of Governors, you'll know that this is a hot topic for them. It was one of their indicators in a previous quality report, and Tracy is liaising still with the governors just to give them an update on what's happening with it. So that's really positive, I think. So thank you for that. Anything else on that before we move on? No, then if we could move please on to item 12, the Mental Health Legislation Committee Assurance Report. Mike Smith.
Thank you, Sharon. So I'll start with the point that Mike was raising, which was the care away from others policy and reducing restrictive information interventions. I think we've established a good sort of working protocol where MHLC looks at the legislative implications and QC looks at the quality aspects of that. And it was nice to see a reference to that in the report, and we've done the same with prone restraint, if you remember. I'll take the report almost as read. One of the concerning things in that report was that learning disabilities mortality review, and we all know that patients with mental health problems have lower life expectancy than others and have more health needs and so on and so forth. But I think that there was a real eye-opener there with the learning disability mortality review, and that might be one that QC wants to have a look at as well. I'd also like to raise the fact that over the last couple of months, we've made some progress as far as Mental Health Legislation Committee is concerned in terms of the work of the committee and its exposure. The work of the committee sometimes is a bit Cinderella-ish and is a bit technical, but we've done a governor's presentation about the work of the committee, and as a result of that, the governors will now be looking at mental health legislation as part of the strategy group, and I think that's a really, really positive thing. The other thing that's happened in the last couple of weeks, actually, is also some training for non-executive directors. And we've done the Mental Health Act and Mental Capacity Act, and it is one of our core activities, and it's something that I think the chairman, Sharon, has agreed that we'll probably do something around that area annually to make sure that we're all in that sort of fold of having at least the basic knowledge about how we deprive people of liberty, how we care for them, and the implications of that, particularly as the liberty protection safeguards come around the corner. There'll be a complete change of environment. So if it's okay with everyone, I'll leave it there. Any questions?
Just before I come to you, Hilary, John, Executive Lead, do you have anything you want to add?
On mute. So it was a very comprehensive meeting. We looked at a lot of stuff, including some operational stuff. And going forward, we've got a refresh of our performance report, which I think will help with that. I think I would echo Mike's point about some of the leader stuff. But importantly, we also had those conversations with the Care Quality Commission that Laura Sheriff from the CQC joined us on the meeting. And she talked us through her impressions of some of the remote inspections she's been undertaking on the trust over the past couple of months, which have been positive. We're not being complacent. So it's good to see that all of those things are just sort of fitting into place. We're getting on with the business of as usual, but we're also sort of looking out and working with the CQC. And it was also useful then to be able to share some of the information about our patient and care experience annual report and what patient feedback is telling us, and making sure we feed that experiential piece back into the Mental Health Legislation Committee as we do into the Quality Committee. Thanks, John. Hilary?
Yeah, just to say that the Learning Disability Mortality Review report has been to the Quality Committee. When it came, Trish Bailey, who was the clinical lead for those services, was actually at the committee as well, and we were reassured that the learning in there was being taken forward by that division. So we're expecting to see that in their quality improvement plan as well. So that will come back to the Quality Committee in due course, and we can see how they're progressing that work.
Thanks, Hilary. That's helpful. Dean?
Thanks, Sharon. Yeah, I just wanted to take the opportunity to thank Mike Smith, really, not just for the in terms of more sort of formal training, but just in terms of the generosity of his time, in terms of updating those of us that are new in some of the background and nuances, and just aiding that understanding that helps us to do that job that little bit better. So thank you for that.
Thanks, Dean. I'm sure it'll be appreciated by Mike. Thank you very much. If we can move on then to item 13, the Finance and Investment Committee Assurance Report. Francis?
Thank you, Sharon. Obviously, in terms of the finances, Peter's given a more up-to-date position than was here. So I'll just pull out 3 things quickly. Firstly, the deep dive report we had on primary care, which shows that the recovery plan is starting to bite. And you can see from that we are showing an improvement on where we were previously. Still not into break even, but getting much closer than it was before. Second one is on BRS, because I think the team needs acknowledging the good work they're doing on BRS. I'm aware of quite a few other trusts who parked BRS once COVID came in because of the top up and are now struggling to restart their BRS schemes when they realise that in the second half the funding is going to change. We haven't, we've carried on, and I think that's a credit to the team. And then the third one is that we discussed it at board a while ago, and we've now had an update on capital, and you can see that in there, including the disposals programme around Victoria House, Hallgate, West End and Chestnuts. Those are the 3 things I'd pull out. I don't know if Pete Beckwith wants to add anything, or Pete Barron wants to add anything.
Pete Beckwith?
I guess we've already had the finance update for month 5 earlier on the agenda, and I think I would have pulled the 3 items out that Francis highlighted over and above what we've previously discussed, Chair.
Thanks, Pete. Peter, is there anything you want to add? No, great. Any questions? No, thank you very much for the report and that helpful pulling out of those 3 points, Francis. Can we move on then, please, to item 14, the Audit Committee Assurance Report. Peter?
Okay, thanks, Chair. First of all, I'd like to say this was the 3rd Audit Committee meeting in the sort of virtual environment that we're having to work in. And from my point of view as Audit Chair, I've seen sort of no dip. In fact, if anything, an increase in the standard of the papers and the assurance given. So I think what I'd like to say to start with is really well done to the team for continuing the standard of papers and assurance that's come to the Audit Committee and all the other committees and the board in these difficult times. I think you've done Pete and the rest of the team, Michelle, everybody's done such a fantastic job there. So really well done. In terms of this meeting, it was on the 11th of August. I just want to pick out, I mean, the papers are there, but I'll just pick out perhaps 4 things. The first one, I think, is we had a procurement activity and assurance report from Mark Turner, and that was very well received. It still shows about 92% of all orders are from the catalogue, and we talked about the procurement of PPE, a new telephone mobile system, and we got really good assurance that despite the virtual working, that the procedures and the controls were still very much in place. And we also talked about the NHS Digital's assessment that they've done on our cyber security, and our level has been assessed as medium, which is very common level. It's what I think we probably would expect for size of the trust that we are. But within that NHS Digital report, there are a number of actions that the board are responsible for sort of overlooking and making sure are complete. And I think obviously the detail of that will be down to the Audit Committee to sort of review that over time. But I think the suggestion was that because it was the board who are responsible ultimately for this, that a paper comes to the October board, and I think Pete will happily have that in hand to give a summary of what this cause cyber assessment was, and some of the key actions and the responsibilities of the board and Audit Committee, and sort of making sure that all is all followed through. Couple of others, you'll note from the report we've had an increase in insurance costs, nearly £100,000. I think that's mainly down to clinical negligence, and I think that's because of the increase of size of the trust more than anything else. And then lastly, I'll just mention, and there's a paper in later on in part 2 in terms of the detail, but we're anticipating a smooth handover of internal audit teams in October. And then obviously we went through a procurement exercise, so that's another activity that was done remotely and through the digital platforms, which went very, very well indeed. And I'm sure that once we come to October and look at the work of the new internal auditors and who we've got there, I think the standards, hopefully we'll see an improvements there, and I very much look forward to that coming through.
Thank you, Peter. That's really helpful. Steve's got a question, John, but Pete Beckworth, is there anything you just want to add before I take questions?
Nothing to add, Chair. Let's go straight to questions.
Thank you. Steve?
Thanks, Sharon. If I may, if I just pick up on the good assurance around the workforce planning, we've invested a lot of time and effort in workforce planning over the last 2 years, and that's been brought through the workforce committee. And I think, you know, in the recent NHS people plan, when you see the emphasis that's put on the future planning, whether that's at a trust level or an ICS level, I just think it's really good that we're having that level of assurance that the processes that we put in place, the things that we're doing in the trust are to the standard that's required and are helping us to sort of contribute to what needs to do. So I thought I'd just want to kind of flag that up, really.
Yeah,
Thanks, Steve. That's helpful. John?
So just to pick up the cyber review, Pete, I think it's really helpful that's gone through the audit committee. I think from memory we also talked about it at Gold. I just saying in terms of the report that's coming to us in October, we are now more reliant than ever before on IT for delivering not just corporate work but also clinical work. And I suppose it'd just be interesting to think about what level of investment may be required to make sure we just don't sit at a medium risk going forward, because I think this is an area for zero risk appetite in the trust, because we have seen nationally and internationally some of the cyber risks. We've had 1 or 2 challenges ourselves, and we can't afford to fall over in this particular agenda.
Yeah, it's a good point, John.
Very good point, and we'll, you know, I think, you know, not to get into the weeds of the detail now, we'll cover that in the paper, which will come via EMT as well.
That's great. So Jenny, we'll note the fact that that paper's coming in October, if that's okay. And I think Pete and I and Michelle have been having some discussions about some possible board development training on digital. So I think Pete's looking into that. So we'll come back on that, which see what the scope that entails. So thank you very much for that report. So item 15, the Workforce and Organisational Development Assurance Report. Dean?
Yeah, thanks very much, Chair. And just first of all, thank you as well to Jess and Steve's team. The Workforce and OD is one of those committees that runs right up to the wire in terms of getting the papers out. So thank you for turning these around so very quickly. The papers there, happy to take any questions, just a couple of highlights. We'd welcomed Grace Garver, who's the new chair of the BAME network. She's very enthusiastic, I think, and will be, you know, a good chair of that network, and will escalate and focus stuff for us. So that was welcomed. We got presentations from the primary and community care division on what they're doing about the staff survey. So what we've been trying to do through the workforce committee is effectively recognise that a lot of the experience of staff at work happens, you know, in the workplace through their line manager, and what locally happens, as well as the corporate support that's provided. So we're just going through all the divisions to ask them what they're doing in terms of their local action planning to improve that experience of staff at work and improve their staff survey results. We got the workforce insight report and welcomed the increasing assurance that was given us about the work that was going on, and we feel we're now in a position where we can start to take a bit more strategic approach from that and sort of edit down some of the detail that we were getting to get a bit of a more narrative update, as well as some of the updates on key strategic themes from that. And I think other than that, I'll just happy to take any questions, really. Steve, I don't know if there's anything that you want to add.
Steve, is there anything you would like to add?
No, that's a good summation. Thanks, Dean. Thanks, Sharon.
Thank you. Any questions for anybody on that? No, looks like some good discussions and good presentations. So thank you very much for that. We can go to item 16, which is the Charitable Funds Committee Assurance Report. Mike Cook.
Hello again, and can I just repeat Dean's thanks to this time to Kerry and to Pete for turning around a report actually from last week's meeting, so you could see it today. Charitable Funds Committee, we met on the 22nd of September, and 3 things to highlight. And Pete, if you could just say a little bit about Whitby in a second, that would be great. The first thing is that Andy Steele and Sophie Holmes came from 360 Accounts and presented the draft accounts for last year early. They give an opinion. Let's get the wording right. They give an independent examination because of the materiality, and they commented unsolicited how much the transparency of the fund zone, sorry, there's a typo there, and the use of zero account have really helped the whole understanding of how we use charitable funds and their flow. It was a really good conversation with them, and subject to some amendments that Peter and Pete wanted to see. We commended those accounts ahead of schedule, and those amendments will be made, and we've asked Pete to action them. So that was the first item. The second item was just to underline, really pleased to see use of the NHS charities funds together for BAME, some investment there done in collaboration with the system. Great. I'm really pleased to see that, and hopefully that's going to endorse the work that Workforce and Steve and the team have been leading to specifically look at BAME, and good luck to Grace in that role leading the network. That was the second item I wanted to highlight. And the third is Whitby. We think it works best with the Smile Foundation when we've got an appeal going. We recommending to the board today the name of the appeal. That certainly does what it says on the tin. And we think that's a strong name for an appeal, Whitby Hospital appeal. And we worked through why the target was what we're suggesting, and we felt assured that that was the right thing to recommend. But could I ask Pete Beckwith, who's leading on that, to specifically comment on that, and then we can take any questions. Unless Pete, Pete.
Lovely, thanks, Mike. So yeah, we had a conversation about the appeal name, and as Mike says, it does exactly what it says on the tin, and I think it'll probably resonate with the local population of what we're trying to fundraise. I think we agreed that the fundraising target of 200 was aspirational but achievable. And I think we also had a conversation in the committee about what we were fundraising for. And actually the committee, prompted by Steve, of course, came up with the idea of actually fundraising as well for some staff health and wellbeing as part of the fundraising target, which was really well received. This paper that then went to the Whitby Project Group last week, and that was supported. And just to make the committee aware, we have got an engagement event tomorrow to get the community involved in how we can involve them in fundraising and some of their ideas for what we could share, some elements of the project, landscaping, etc. And I'll stop there, and I think if we open it up to questions, is that okay, Mike?
Yeah, thank you. And we've just got the minutes of the 21st of July meeting as well with the report. So over to colleagues.
Yes, thank you both very much. Michelle?
Yeah, no, thanks, Chair. Thanks for your work on this. I mean, absolutely support the Whitby, and I think it's great, does it, what it says on the tin. I think that'll go down really well with the population, and I think it'll also help significantly because there's been a little bit of politics in there in relationship to the future of the hospital. So I think this will really cement it that we are, we're developing the hospital. It's for the community. So I think that's really good, and I really obviously will continue to endorse that. And if there's anything else we can do, then certainly let us know. The BAME, it's just to say well done, because what a great achievement in a short space of time, and I really look to see how we develop that work and the charity money going forward. So it's just to say well done on those two pieces particularly, but I know that the work is immense anyway, but fantastic on the BAME, but really supportive of the Whitby name.
Thank you, Michelle. Can I just as well acknowledge the Whitby Governor Doff's contribution to all this. I know she's working very close with you, Pete, isn't she, in terms of the engagement with the community particularly, and with the members of the trust and the communities, etc. So I just want to acknowledge Doff is working very hard behind the scenes, and I know liaising very closely with Pete with appropriate involvement, but trying to help with particularly with the engagement with the communities. Can I echo what you both said? Thank you for turning around the workforce and charitable funds ones really quickly, because I know it was extremely tight and they did go out with the board papers. So fantastic. So thank you very much for that. Can I suggest that we just have a 10-minute break now? We've finished that section, so it makes sense to have a break now. So it's if we can just come back in 10 minutes, so say just after 20, so say 21, to give you a full 10 minutes to have a bit of a break, and then we will carry on with the rest of the board meeting starting at item 17. So see you in 10 minutes. Thank you. All right, well, welcome back. I will just remind people that we are meeting in public. It isn't a public meeting, but if anybody who's watching has a question and has sent a comment or a question in, we will respond to you outside of the meeting. So we'll do that separately. So thank you very much. So moving to item 17, the COVID-19 update report, Lynn.
Yes, thank you, Chair. So hopefully people have read the paper, but just some brief, I guess, sort of comments to set the context. Obviously, I don't need to tell you all that obviously over the last few weeks, there has been a rise in the number of cases of COVID locally and nationally. The national incident threat level was raised a couple of weeks ago to level 4 from level 3. The NHS incident threat level, however, remains at level 3 currently. So we continue obviously to ensure that we are doing everything that we can to make sure that our plans are robust and we're managing the rise in prevalence of COVID within those planning arrangements. Our emergency planning arrangements remain in place. We continue with our gold, silver, bronze commands. Michelle's already mentioned that one of the changes that we have made is to incorporate winter planning into our COVID planning through those command arrangements. We did step down the frequency during the week for our silver tactical and silver operational commands from a frequency of 3 times a week to 2. Through August and September. However, given the prevalence increase, we have just stepped up the frequency of the silver operational and tactical again to 3 times a week, and we'll obviously keep that under review. Obviously, our business continuity plans continue to be of relevance to us. We are expecting potential further rise in cases and potential impact on our services. We're undertaking an exercise currently just to review all of our business continuity plans across all of our service areas to make sure that we've properly learnt any of the lessons from the first phase of COVID and that all of that is incorporated into our plans. Staff availability, as I've discussed before, continues to be key in our ability to deliver our services safely and well. So we continue to monitor the impact on staff sickness very closely. You'll see from the data that hasn't risen a great deal. It remains quite low overall. However, what we have seen, particularly over the last couple of weeks, not surprisingly, in line with the increase in cases, is quite a significant jump in the demands for our staff to be tested. So that hasn't raised the rate that we're seeing particularly at the minute, but I think that is an indicator, obviously, and one we would expect to see at this point in time. We continue to focus on our testing arrangements. There are some issues locally and nationally that you'll be aware of around particularly capacity in Pillar 2 testing. However, we continue to have our staff tested via Pillar 1 in the main. And whilst there's been a bit of slowdown in receiving of some of the results, that is working reasonably okay for us, but we keep it under close monitoring. We've had no issues with availability of PPE. We've still got our arrangements in place. They're working well. We did receive an update in infection prevention and control guidance through Hilary and her team. We've reviewed that and we have taken that into account, and that's now in place. That particularly required us just to look at particularly our inpatient areas and carry out sort of the criteria around placing them into particular risk categories. But again, there's some information in the report around that. We continue our focus on staff health and wellbeing. We've already talked about that already this morning. That remains obviously critical to us. Whilst our sickness absence is in a good position overall, what we have seen is a rise in referrals to our occupational health department for staff who are experiencing mental health issues, stress, anxiety, depression. So all the more reason really why we need to keep up our efforts around supporting our staff health and wellbeing. Obviously, we've had a lot of activity and Pete and his team have been involved in that, as well as the operational side around the phase 3 planning, ensuring that we've understood what our impact of activity is going to continue to be over the next quarter and into next year. So we're satisfied that those plans are robust and working on those still at the moment. And there's one element I didn't make reference to in the paper because it was still embargoed at the time, and that was the release of the national NHS COVID app. You'll be aware that that's now in use, so we've obviously considered the impact of that in terms of our services, and maybe that's very low. So I'll stop there, Sharon, and pause for any questions.
Thanks, Lynn, and thanks for the paper. Useful as always to have it all pulled together for us, so thank you for that. Any questions for Lynn on the paper? Francis.
Thanks, Chair. Lynn, just a couple of questions. So just with my Dooms hat on, what is the worst case scenario that we've planned for in winter planning? So what are we taking as our absolute worst case in terms of we've got no staff, everything's gone through the roof, flu pandemic struck, you know, what's the absolute worst we've planned for?
So our sort of surge plan, Francis, has accommodated up to 30% staff absence and potentially above as well. So our continuity plans therefore have been set in the context of what we would do with a 30% staff absence, and actually what the core services would be, those that obviously would keep running, where we would redirect staff to, and those services obviously as a consequence of that we'd need to stand down.
Okay, that's helpful. In terms of Whitby, obviously we've got a lot going on. Where would COVID patients go if Whitby's not going to accommodate?
So we're still waiting for final confirmation from North Yorkshire around that. We do expect it to be likely that Malton will accommodate COVID positive patients. That's what we're anticipating, but it still hasn't been finally confirmed.
Great, thanks. Really comprehensive, so thanks very much.
Thanks, Francis. Good first question. Interestingly, Michelle, Lynn and some of the others had to do some scenario planning with the military, actually, based on a scenario not that differently from that, didn't you, actually, a few months ago as well. So there's been a lot of planning going on behind the scenes. Any other questions for Lynn on that paper? No, as I say, thanks, Lynn. Really helpful to have it all comprehensively pulled together. So appreciated. Thank you. So if we can move on, please. We've done item 18, the Guardian of Safe Working. We've already met with Jennifer. If we can move on to item 19, the Infection Control Annual Report, Hilary.
Thank you, Sharon. Yes, as we said earlier, this was presented to the Quality Committee in August for approval, and it's here today seeking board ratification. I think anyone that's read the report, hopefully you all have had a good look at it. You'll see the main achievements are against the infection control strategy. Very positive achievements, particularly in relation to some key work programmes around healthcare acquired infection. We've had 0 C. difficile, 0 MRSA, mandatory trainings, good compliance, no inappropriately placed urinary catheters in our community wards, and this work has now been extended to roll out into our community service as well, so we'll be looking at it in the community. As you see from the report, it goes into March this year, so it does pick up the beginning of the surge in COVID and the impact on services and the team. As I know we keep saying this, but they've been an absolutely fabulous team all through this. They've really stood up to the ask, and I've got nothing but praise for them. I get such fantastic feedback from the clinical staff, the way that this team has stood with them in some really complex situations and supported teams. So it's not been an infection control team in an office as where that's directing staff how to work. Particularly in a pandemic with patients, they've actually been there with them, with the patients, working through some of the complexities. I'm beginning to imagine some of the complexities with that patient group, but particularly in places like Maester, where we've got patients with dementia, and that's where I think a lot of their effort has been working with them. So actions for this year are captured at the end of the report moving forward, obviously all aligned to the infection control strategy that the board signed off, but obviously a big focus now around that impact of COVID, increasing capacity in the team, big thing around communications, which I know we've already said this, but they've been absolutely fantastic, the communications team, in supporting all of this work, working with the infection control team, putting posters together, getting the message out there, and that's how we're going to continue, because I think that's really helped to support our efforts so far. And also a big focus for the team now getting that virtual technology in place to provide that online training and support to staff. So happy just to take if there's any questions on that annual report.
Thank you, Hilary. Mike Cook.
Brief comment. Quality Committee really commend and recommend a great report with lots of assurance, good outcomes, a fantastic attitude from a small team who get very good feedback. I think we should commend them in some way because of the time that we're in and the impact and influence they're having on all of us.
Thank you, Mike. Absolutely. John?
So, Hilary, it's really weird looking at the report and seeing people standing beside each other, and I'm going, why aren't they wearing masks?
It is, isn't it?
So it's a bit like the old world, new world.
Yeah.
Just to echo everything you've said about the team, they've been fantastic. And I think their challenge has been a logistical one, but a cultural one. And what I would just feed back to the board is my observation from being on some of the units over the past 6 months is I don't use the word of compliance with wearing masks, but it's really interesting to see that it's just everywhere you look, people are doing the right thing. I think the change into scrubs now into uniforms will be helpful in terms of infection control. And I'm struggling to pick up episodes where things aren't being done in the right way. So I think that's the COVID will be really positive going forward in terms of wider sepsis and antimicrobial work that we need to do as well. So well done to the team.
Thanks, John. That's really helpful. Francis?
Thank you, Chair. Just to echo everybody's comments, really, really impressive, really, really good report. Well done to the whole team. And then just one question. It was around the Peeler House work and the worry around, is it Legionellas and the water system? Just wondered where we'd got to on that at all.
Do you want me to answer, Hilary?
Yeah. You'll have a more up-to-date position.
Yeah. Both have come back with clear samples now. So they were both long-standing challenges. Francis, Humber Centre, we ended up replacing showers in the used ward, and we've had clean samples back now. So that one has been signed off as complete by the water safety group. And the same with Peeler House. The most recent samples we got came back as clean, and therefore the water safety group were also happy to sign that one off now.
Thanks, Pete.
Thank you, Pete. Michelle?
No, just to echo what everybody said, really, it's a great report. I do think it does seem like a lifetime ago. I think as Dean's commented in the message box, the pictures of people stood together and actually shaking hands and what have you, it does seem a whole lifetime ago, but we are where we are. But I think, we've been ahead of the curve a lot of infection control in the pandemic, and that's in the main due to a lot of the work that the infection control team have put in. And we did mention earlier on they're a very small team, and when you think about our geographical size, we have mentioned about everybody having downtime, including the infection control and prevention team. But I'd just like to thank them on behalf of the board, as Mike has, as everybody has, just to say well done, and do make sure they get some time off, because it will be a challenging winter. But fabulous work up to now, fabulous.
Thanks, Michelle. Is there anything else on that? No, absolutely. Can only echo what everybody said. I mean, I see them on calls sometimes, Hilary, and what they've achieved, and to produce this report, you're right, you wouldn't know it was an extraordinary year. It's always comprehensive when it comes to the board anyway, but this year particularly, massive achievement. So please do pass on our thanks for everything that they've done. So we're asked to ratify it then. Are we happy to do that? Yes. Yeah. Okay, that's great. Thank you. Thanks for that, Hilary. If we can move on to, we're sticking with you, Hilary. If we can move to item 20, the Humber Safeguarding Annual Report.
Yes, thank you. And another report that went to the last Quality Committee and was approved, again seeking ratification today from the board. I think the report, it's an extensive report, but it really does present the breadth and the complexity of safeguarding, obviously on the national picture, but particularly everything that's going on in the trust. The team don't work just in, they work out an awful lot as well with partners. This report has been to partners in a draft form, has been very well received, particularly at the safeguarding boards, where they've also had a look at the report as well. And just like the infection control team, this safeguarding team are absolutely embedded in clinical practice. They support the clinicians, they support patients with complex needs around safeguardings, and they're built into our patient safety processes as well, which is not an awful lot of trusts do this, but ours particularly, they support and sometimes lead on incident investigations, particularly obviously where there's safeguarding concerns. But they also work with the long-term segregation reviews and the care away from others reviews, and they lead those reviews and do the reports on those as well. So they really have got such a breadth to them, and they're really touching that frontline clinical service. So they've always got that temperature check around safeguarding in the trust. Obviously, hopefully you've had a chance to look at it, and I'm happy just to take any questions on any of the particular elements on it. And I'll do my best to respond.
Thanks. And Mike's already mentioned that the Quality Committee commend this report already. John?
So, Hilary, I'd like to commend the safeguarding team in terms of bringing safeguarding to life, whether it's through modern slavery or indeed the domestic abuse work and the sort of white ribbon work that we're engaged in as a trust. And I think to engage all of our clinical colleagues in this, medics and stuff, it's understanding what safeguarding is all about, which is improving the quality of life for vulnerable people. And I think safeguarding are really taking that to a new level by featuring on these sort of key events. So I want them to commend them to that, because I think it just makes it easier for people to engage in what is a complex and difficult area, but it's something that needs attention.
Thanks, John. Peter?
Yeah, it's a really great report, this, and it gives us a lot of assurance. But I guess I wasn't at the Quality Committee in terms of how they're working post 1st of April and in this COVID world. I mean, they're quite a gregarious bunch, the safeguarding team. How are they coping, and how are they managing to get assurance, if you like, given that everybody is self-isolating and staying apart and working virtually? It must be an awful lot more difficult for them to sort of be aware of concerns in this environment than it was before. And the fact that people are at home more in family groups and whatever, it might be that the amount of concerns are actually increasing. And I just wondered how we picked that up.
Yeah, I mean, Peter, what you've described there is the national picture around safeguarding concerns, things being more hidden, particularly in children when the schools were closed, very, very concerned. And I know I've raised that at previous boards where we're concerned. And certainly the Quality Committee, we picked up, didn't we, the drop in referrals when we really hit the pandemic. However, those referrals for us internally have gone back to normal. They're back at where they should be, so that's good. And that's, again, staff awareness. We've done a lot of work with staff. We've put checklists in place for staff that are predominantly seeing patients now using digital methods, so making sure that they are aware, looking for those safeguarding cues, some questions, prompts, etc. The safeguarding team are going to multidisciplinary team meetings using Teams to do that. So they're not actually going and sitting in there, obviously, but they will use Teams. So in some ways, they've actually got more access now, but it's obviously through the digital means. They are working very well. We're getting all the referrals in that we would expect to see. They are, again, still focusing on individual patients, and I say using digital platforms to do that. What we are doing, the care away from others and long-term segregation reviews that we've got in the trust, I'm part of those with the safeguarding teams, and that we're doing those, as you know, digitally. But I've really been quite concerned that since April we've not actually seen the patients because of the digital nature. So myself and the head of safeguarding have got a schedule of meetings to go on and actually see all of these patients on the units as well. Obviously all on different days and using proper PPE, etc., to go and see them, just to make sure that we have seen them as well. So again, that's the safeguarding coming with me to check that out as well. So I think I've already done one, and there's another one tomorrow, and we're rolling those out over the next few weeks just to make sure we have actually seen them.
Thanks, Hilary. That's really helpful, actually. Additional information. So thank you very much for that. Anything else on this report? No. Jenny, can we just make sure it goes back on the annual board plan, because it went via a committee, but then Hilary quite rightly has asked if it can be put back on the board agenda, so that's why it's come back to the board. So we're asked to ratify it. Are we happy to do that? Yes, thank you very much.
Yeah.
If we can move on then please to item 21, waiting times update. Lynn?
Yes, thank you, Chair. So again, I'm assuming people have read the paper. I think it was obviously already noted that there has been a bit of an upturn in the RTT waiting times for incomplete treatments. So, however, and before somebody else tells me one data point is not a trend, so we just need to keep the focus on this area. So what the report sets out is that the position around waiting times for over 52 weeks are predominantly due to 3 key service areas. So the first one is Department of Psychological Medicine, then the Memory Assessment Service, then the CAM service, but particularly those waiting times for neurodevelopmental assessments, particularly for autism and ADHD. And obviously it's a conversation certainly that we've had many times previously at the board, particularly around the issues that underpin those CAMS neurodevelopmental waiting times. They are long-standing issues. Unfortunately, they have been impacted further by COVID, and specifically the inability for us to adapt all of those pathways, although that's not despite the efforts that we've made to do that, to work effectively across digital platforms. Now we have made progress with that, and where we're able to, and the paper sets some of that out, we have translated some of those pathways in order to be able to undertake assessments. But for some very complex young people, particularly with autism and ADHD, using the digital platforms just isn't clinically appropriate. It doesn't work well enough for us to reach a safe diagnosis. Obviously, the impact of the schools being closed through the first phase of COVID impacted the waiting times. Some of the critical information in order to make a safe diagnosis comes from the education system, and obviously we weren't able to collaborate with our education partners to do that. So there's a lot of work that's been undertaken now. Obviously we are in a position with the support of our estates colleagues to make physical space back available again to see families and young people. So we're working hard, that's already happening now. In terms of the Memory Assessment Service diagnosis pathway, that was specifically impacted by the lack of availability or access to imaging by the acute hospitals, again a necessary element to support diagnosis. Now that access is there again now, but it's probably less available than it was previously. So I'm working hard again with the acute hospitals to make sure that that's readily available to us. In terms of the Department of Psychological Medicine, again, that the manner in which the interventions are delivered through that service is primarily through an outpatient type model. In the initial phase of COVID, we did prioritise through urgency and risk the work that we did around that service. And again, we've in-housed that service recently with some additional resource. Our expectation is that waiting time will reduce. The paper also sets out how we manage waiting times, our expectations around particularly the risk that poses potentially. Each of our areas has in line with the waiting times policy that we've already got, a standard operating procedure, particularly for their area. That requires them to maintain a weekly and daily, in some cases, oversight of waiting times, and to be in regular contact with service users, their families and carers, in order to understand and provide information, obviously effectively, around what's happening, but also to prioritise clinical risk, and obviously to see those service users who require urgent intervention. A version of this paper is also going to the Quality Committee next week, and that version will actually set out a bit more detail around how the quality impact elements of waiting times are further addressed by those divisions, by those service areas that have them. So I'll pause there if that's okay. I can see hands up.
Yeah, thanks, Lynn. Mike Cook.
Thank you, Sharon. Thanks, Lynn. Looking forward to a discussion at the Quality Committee next week, where we'll look at this, which the board had asked us to do. I'm just thinking about the provider collaborative, and we're also got that on the Quality Committee agenda too. Any implications having long waiting lists here and presumably some elsewhere for the provider collaborative? Just a thought. You can come back to me on it, but it's something that I was thinking through when you were going through it then.
And others may well come in, but I guess my view, Mike, would be that obviously the provider collaborative is specific to areas of specialised commissioning. One of those areas is CAMS specifically. So, and although it's around the tier 4, but what it does enable us to do is really look at, how we actually develop across the provider collaborative pathways that actually allow us on our geographical patch to manage the demands, I guess to some degree, with actually more freedoms, perhaps. So I know there's work that's already underway through the mental health and LD programme on the ICS around autism. So I really think there is opportunity for us to look at that going forward in terms of how we utilise that approach to make improvements. I think that's a really good point. I'm quite optimistic about that. I do think it provides a really positive opportunity.
Shall I just come in there, Chair?
Yes, of course, Michelle.
And I mean, building on what Lynn said is absolutely right. I mean, obviously this is the commissioning piece, is the lead provider, but one of the things that we are doing, because it is specialist commissioning, and obviously it's eating disorder, secure and children's services, children and young people services. And one of the things that we've started to do as we start to establish our governance processes and our systems internally is I'm linking that in now to the strategic commissioning discussions that I've been having with the CCGs, which relate into this waiting list, because it is sometimes about pathways, but it's also about spotting children and people sooner in the system as well. So I'm also picking up some conversations with the local authorities as well, particularly, as well as the CCGs, about how we can start to, whether it's a care pathway, but how we can join the system together a little bit more so we can actually start to pick up the people earlier and quicker. But also to have that smoother transition between the two. So I'm hopeful, because the strategic commissioning piece is ongoing at the same time as the lead provider work, that they will dovetail together. But we need to make that happen, because it's a really good point. The other thing is, we've just appointed, with my other hat on, with my systems hat on, I've just appointed a lead for learning disability and autism particularly, because we do need a more joined up position on autism. One of the local chief execs leads the autism group at the moment, and we've got a particular project lead on that as well now, because we need to, as a system, look at where the independent providers are, because they've got a really useful part to play in this work, but also where the workforce is as well, because as we know, it needs specialist workforce as well, which is sometimes part of the issue. So we're looking to see if we can join that up a little bit more together, and maybe have something like a lead provider type approach to autism going forward. So that's the other strategic piece that's taking place with my other hat on.
Thanks, Michelle. That's really helpful. Mike Smith.
Thanks, Sharon. First of all, really good report, Lynn, and very, very well presented, comprehensive, and shows the real grit that there is on this. Michelle had started to answer my question, actually, which was about commissioning, but I'll still carry on, because Michelle's talked about the strategic level, and I'm just wondering what feedback we're getting from our commissioners, because it could vary between, well, you're doing your best, just carry on doing the good work, or what's happening here. So what's the flavour of it, Lynn, please?
Yes, my really good questions. So particularly around the children and young people's neurodevelopmental pathways, for the reasons that Michelle said, actually, there already is a lot of joint working with our local authority partners, with the CCG, with ourselves. We committed actually to redesigning and redeveloping the neurodevelopmental pathway, and actually we've already made some of our changes that are incorporated in this paper in line with that. But there's more work to do as well. And I think Michelle's made, as we've discussed here, the really good point that, some of the young people are reaching the threshold for assessment, when actual fact, if more had been put in place, whether at school or to support at home, then actually a lot of these referrals probably wouldn't happen. So, and I think there's been real understanding, collective working, that, that is where we need to focus. And in the paper, and actually it was in my element of Michelle's chief exec report as well, particularly that in Hull, there's been further investment, particularly around putting mental health support into education as well. So I think all of that, there's more to do, undoubtedly, but it does feel like we are all on the same page, collectively with this and collectively owning the issue. So, and I think the view is that, you know, we are doing what, you know, the system wants us to do, and you know, and that's been received positively in the main.
Thanks, Lynn. Anything else? I think it's great, and I know we asked the Quality Committee to have a look at this, so I think it'd be really good to look at the quality impact of this next week. I think it's really important that we do that, and probably the trajectories as well, probably, Lynn, I think, in terms of what we're expecting when. Just one from me. In terms of these, you've mentioned in the paper something about the trajectories, and I'm sure they'll be discussed more at the Quality Committee next week, but which of these concerns you most, Lynn, in terms of, you know, sort of so you've already said you're optimistic about, I think, memory assessments, for example. So which of these is the most concern to you, really, in terms of being able to recover and improve the physician?
I think it's a really good question, Sharon. I think we can recover memory assessment service. However, we are slightly dependent on the acute sector for the imaging element of that. So that's partly why I've actually taken advice from Pete's BI team, but because there was such a step change in these pathways because of COVID, to actually produce trajectories that are robust and make sense, we just did need some of the elements to be a bit more finalised before. So we are in the process of developing those trajectories for the reasons that you say. Probably, Sharon, I think it is the CAMS element still, because of this sort of systemic issues associated with that. We're making progress, but the progress is slow, and it is, you know, it's necessary for us to work with our system partners. I think, as Michelle's described, there's lots of reasons to be optimistic about that. There's more work that we can do, but these issues existed prior to COVID, didn't they? Whereas the psychological medicine service and the memory assessment service are more due to, you know, that impact that we've seen, you know, since March. I think we can recover that. But the CAMS bit, I think we really got to pay attention to. We also know, don't we, and it was again that we're expecting not just the usual demand for CAMS service, but we're projecting a higher demand as well going forward because of the impact directly and indirectly in relation to COVID too. So I'll pause there, but CAMS for the reasons that I've said.
No, thank you, and that's helpful. And I think you're right about the demand. We can all see that from our own lives, can't we, in terms of looking around. And I know that you're right about the education piece. So my own children's school are investing heavily with Mind, and I know they work with the trust as well, but there's drop-in sessions, there's opportunities for parents and children. It's really, to be fair, they've really ramped it up in terms of the offer that is available through school, which hopefully will help children get the help they need as soon as possible when they need it. Okay, well, that's really good. Well, I'm sure we'll look forward to the next Quality Committee assurance report when the Quality Committee have had opportunity to look at this in more detail. But it's a really important topic, as we know as a board. So thank you very much for that. If we can move on to item 22, which is the Yorkshire and Humber care record. John, is Lee joining us for this?
Yes, he is. He's on the call.
I am on the call.
Sorry, Lee. I didn't really
understand when Lynn started, so I am on. So yeah, I'm here.
Well, welcome to the board again, Lee. So, John, if you'd like to introduce this.
So very quickly, we talked some time ago, pre-COVID, about just bringing an update to board on the work of LICRA. Or the Yorkshire and Humber care record, should I say. So I'm the SRO for the programme, which is hosted within Humber, but it's obviously a national exemplar which runs across Humber, Coast and Vale and the other ICSs as well, and it's one of 5 national exemplars. This is about a bit of a clinical and a technical update. So Lee will talk you very briefly through a short paper that we've produced, but we really welcome the opportunity to have a conversation or some questions that people may have just to bring the care record to life. And secondly, to note, there is a financial governance piece. Peter Beckwith is the finance lead for this, and we take the finance separately into Finance and Investment Committee, and it's reported on separately through the board assurance paperwork from finance. So we're just going to focus on the clinical piece and the technical piece today, with a very short piece to keep you all interested in it. So Lee, over to you.
Hi. Paper has been shared already. The main points are we've now left the formal LICRA process with NHSX. and we have developed a value case which has been approved by the 3 ICSs or 2 ICSs. We've had an agreement in principle of Humber, Coast and Vale. Obviously, we've had some issues with COVID, etc. So it's going to the next meeting with John Skidmore, exec meeting. We got rated as amber green by NHS as a LICRA. We was the only people to finish against the original schedule, against the original requirements. Some of the amber items are slightly disappointing because it was outside of our control. There was dependencies with the wider system, but that didn't stop our progress. We did some good work with an academy that we've set up. We've run the first cohort. It focused around population health to start with, which we've had 40 people through. That's clinicians, managers and BI experts, of which some of the members of this organisation have been involved. Got a meeting, to be honest, with Health Education England after this, later this afternoon on the second cohort, and that focuses on, as well as pop health, on the technical aspects, which you've also picked up during the process of developing the Yorkshire Number Care Record and connecting to it. It is a very big development need from a technical point of view, but also how do we use these systems. We have made progress on sharing transfer of care documents. So this is really around ambulance services sharing to A&E, where we had a webinar last week where the A&E consultants presented that back to the wider system. It was more of an internal focused one to really get that critical mass and interest moving. We have got external webinars being scheduled around some of the other functionality. The other item there, which will soon be coming live, is the access to mental health care plans. So we've actually been live on the record for quite a period of time. We've just been working with our colleagues to make sure that they can access our data, and then that to be used for obviously that emergency care situation. We have a pipeline of organisations joining the Yorkshire Number Care Record, which is shown below. The pipeline goes through a number of stages, just helps manage where everybody is, whether they're live, going live, connecting to test, etc. So overall progress is probably less progress than we expected to have connectivity than would have expected. COVID had some impact on that, purely because most of our providers focus very much on how do they support COVID rather than shared records at the time. That has flipped significantly, and that includes some of the additional work we've picked up. So we are working very closely with the Humber, Coast and Vale emergency care team on using the Yorkshire Number Care Record technology for 111 first, or talk before you walk, depending which solution you're looking at, and that links the clinical as well as the pathway aspect. So that's a good show of how we can use that capability in a better way. And the other one is supporting the COVID-free planning, where we've finally had the confirmation from NHS what that means against the original letter, which is for each region or ICS to have a plan for integrated care record. Sorry, shared care record is what they're referencing now, and population health, which we are in a good position, and we're currently working that plan up with Humber, Coast and Vale colleagues, and also our other ICSs in Yorkshire and Humber. The final point, just to round it off, that it links very closely to our development of the patient portal. Now, the patient portal, we haven't deployed in Angers yet, apart from the video conferencing, which you may have heard about the product called Upstream. That's part of that development, which has been invaluable during these difficult times. That links and seamlessly integrates with the Yorkshire Number Care Record.
Sharon, would you like me to lead on the Q&A in this? Because I might be able to answer some of the questions as we're going along too.
Yeah, that's fine, John. John, I'm just conscious this is a meeting in public. Can you just sum up in a couple of lines? Thanks for the update, Lee, and for the information. That's fantastic. But can you just stop on what difference this makes to patients and their families? Because I think that might be helpful in terms of, it's the detail. We need to know the detail, but I think if we could just remind ourselves what the whole purpose of this was, and just in a few lines what the benefit is to patients and their families, that would be really helpful. And then yes, by all means take the questions for this section. That's fine.
So, in a few lines, the system has always wanted health and care records to be linked up. And that would improve patient experience because they wouldn't need tests being repeated. It would also improve clinicians' experience because they can see what other clinicians have done, and would benefit the system because there'd be less waste. So basically, yes, it is about efficiency, but it's also allowing patients and citizens to have greater control over their own health and care. We couldn't historically do that because clinical systems and health and social care weren't linked up. And as one of the 5 national programmes, we're hoping in Yorkshire and Humber to be able to do this as soon as possible. Now, having linked care records is fantastic, but a care record is only a care record unless you have a care plan. And the key piece for us as clinicians moving forward will be to use the fact that the systems are linked up to share the care plan. So whether you have a physical health problem, a mental health problem, or both problems, it doesn't matter who you interface with, whether it's a GP, an ED department, an out-of-hours service, an ambulance service, people will have a clue as to what is the plan with regard to your needs and your care. But we can only do that by linking all the systems together. So that in a nutshell is what that's all about. What I would say just to add is that in terms of the phase 3 recovery of the NHS, there was 2 lines in that which said that every ICS must have this as a must do by next year. And we are one of 5 regions to have that pretty much already in place, which is what you can see was the technical plan. And one of the reasons for the success of that is that the 3 ICSs got together 2.5 years ago and agreed to back this at risk. And because we backed this at risk, we've got the innovation and we've got there. It would be remiss of me not to thank Lee Rickles at this stage, because actually he's absolutely dragged this over the line from a technical point of view, and he's had those conversations across the system when it comes to encouraging people in the north to invest with their own wallets on the nitre load. So well done to Lee. But I think we will see the difference of this a year and a half down the road, but we have to build the foundations first, Sharon. It is slightly dull, it is slightly technical, but it's about building the foundations, and we're well on with that, confident with that.
No, that's fantastic, John. I just think, as I say, we're meeting in public. I just think it's helpful to remind ourselves what, in sort of lay terms, what the whole purpose is of it, because it's so important work. But yes, feel free, John, take your questions.
So, Francis, could you give me a hint? If it's a techie question, I'll direct you to Lee.
Right. Well, you've answered the second half of my question, and also I noticed Mike put his hand down, because I think we're both going to ask the same thing. But so from my perspective, in plain English, who can actually see what now?
Who can see what now? Oh, Lee.
Okay. So for the Yorkshire Care Record, so GPs in Humber, Custom Vale, or 52% can see information on cancer patients. In Leeds, they can also access transfer of care data from the ambulance service. Rotherham and Leeds can also see emergency care data, Francis, and a number of trusts. So Rotherham and Leeds can also see wider GP and community data. That's where the footprint's expanded at the moment. We are in the very near future going to be able to provide acute and emergency care access to Hull University Hospitals, York, and North Lincolnshire and Gould Hospitals. They're just connecting as we speak, Francis, and the other way around for the GP. So we're going to be on the cusp of something quite spectacular, realistically, in the next 3 to 6 months, for the ability to have that information available to support that wider patient care.
Okay, thanks.
Peter Barron.
Oh, hi. Oh, thanks very much, Lee, for that comprehensive report again. The question I've got is, I think you mentioned that there are 5 of these projects around the country, and I guess from my point of view, is there shared learning between the 5 in terms of what's going right and what's not going so right, and also when you're doing the testing, presumably that you're feeding back into learning and making various alterations to the way that the system is being developed. So perhaps you could just talk around that, how it's all shared and what you learn from testing.
Yeah, so we have So we do, Peter. You're absolutely right. So there's an architectural group which carries out that role very much from a technical point of view, because a lot of the work we're doing from an extremely technical perspective is quite new, and it's created a number of challenges. We've also included the professional body, the professional record standard body in part of that work as part of a lessons learned and reflection piece. So we can tie the technical to the clinical and professional aspect. The final aspect on there is the clinical leadership aspect, which is chaired by Simon Eccles, the Chief Clinical Information Officer at NHS, and carries on and covering the actual how do we really use these things, how do we make it real. And in a number of cases, it is very much sharing. It's very much more show and tell, very QI orientated, Peter. That it's quite vibrant in that respect. We're all going slightly different directions because we're using different approaches, which is a reason for being an exemplar. There'll be a review during this year of which are the best bits of Oldham exemplar to inform the wider shared care record approach for England.
So, Peter, can I also just touch on information governance to say that NHS oversee that? So in terms of Caldecott principles, that is all absolutely nailed down as well, because from the public engagement work that we did about 18 months ago, one of the real understandable anxieties from the public was about how we were going to use the data from a primary and a secondary point of view, and that's crystal clear on our own website what the data is for and how we're going to use it, and that's in line with NHS and national guidelines. So just to make sure that people understand that we're being open and transparent about how this system is going to work. The interesting thing to note that Lee hasn't said is that actually some of the work that we've done in Yorkshire and Humber, we now have external interest from Wales, and we have other systems now coming to us saying, look, can you support us to go from point number 1 to point number 2 in this? And that's I think a reflection of the expertise we have in the team, but also the fact that we've built up a little bit of a reputation around delivery. So you won't see us out and about at conferences shouting about the work that we've done, because I think, as Lee has just alluded to, we reckon it's another 3 to 6 months before we really feel we can bang the drum about something to shout about. So that's it, I think, in terms of questions that I can see. Sharon, shall I pass it back to you?
Thank you. Thanks, John and Lee. Thank you both very much. And as I say, Lee, thank you for coming again and for the comprehensive update and for all the work that you're doing, because and it sounds like the next update is going to be really exciting in terms of, you know, real sort of gear change of what you've achieved. So it really is important, as John described, in terms of the impact to patients and their families and to the staff, and to be able to do the work that they want to do for patients and staff. So thank you very much, Lee, and thank you, John, as well for that. So feel free to join us if you like, Lee, but I'm sure you've probably got other things to do. So thank you.
Thanks for the offer, Sharon. I'll drop off, but thank you very much.
Thank you,
everybody. Bye.
Bye.
So could we please move on to item 23, which is the board assurance framework? I think a couple of people have got a bit of technological issues. So Michelle and Mike Smith keep dipping in and out. Mike's back with us, and hopefully Michelle is, but I'm afraid it's a bit inevitable sometimes, isn't it? But Michelle, are you with us? No. Okay. Well, shall we just take the board assurance framework then? We've got it here.
Sorry, Chair, I'm here.
Oh,
sorry.
cool.
Sorry, every time I put my power lead into my computer, Teams goes off. So apologies, I'm clicking between my iPad at the moment. Board assurance framework, I'll be very quick. It's agenda item 23. You'll have obviously read it. I think it's 234 in the pages. Positive and negative assurance has been updated. I do thank Oliver, because obviously he's put all this together for us. The executives have looked at and reviewed all their particular areas and their particular assurance sections, have the subcommittees, and I thank the subcommittees for that. I think last time we particularly noted gaps, so we've concentrated on the gaps and the actions, and they are now in line with the risk registers, because one of the things I was concerned about was to make sure that everything is aligned to the various risk registers. So and they are. The ratings remain static. They're there in front of you, and I'll just pass it over to the board, Sharon, if there's any comments.
Thank you, Michelle. Any questions? As Michelle said, a lot of this has been through the various subcommittees. I know because we can see that from the minutes and the assurance reports. Anything additional anybody wants to ask? No, thank you very much. If we can move on to item 24, which is the risk register. Hilary.
Thank you, Sharon. So I've got the risk register here. I say it's been EMT, directors have looked at it and reviewed the risks. We've got 9 risks now rated 15 or more on the register, 4 are workforce, 1 financial and 4 COVID related. And it last came to the board in June, and 4 have been de-escalated since it came to June, which were all COVID related. So I'm just happy to take any questions, which obviously the execs will pick up for their particular risks if there's anything anybody wants to pick up on the risk register.
There are a couple, and again, this has been, I know that relevant sections have been to the committees. I'll start with Peter Barron, please.
Well, thanks very much, Hilary. Yeah, I think at the audit committee, I think with having the cyber cause review, I think one thing that we did was we went back and said to Pete and the execs to perhaps have a look at the cyber risk to see whether that was in there at the right level. And I'm sure that's, through EMC, that's something that you'll do, bearing in mind the cause review that's been done. So I just wanted to flag that to the board that that was a referral really from the audit committee.
Thank you, Peter, for that. Francis?
Thanks, Chair. Just a minor one from me, which I did raise in Finance Committee for our risks, is that it's great to see that Oliver's and the team have now put in timings on the additional actions to be completed, which is great. But just one minor point, just about every single one of them is for today. So obviously I wouldn't expect it in today's thing, but just to flag that next time round, hopefully we'll see some results from all of the actions that are due to be completed by today.
Thank you, Francis. I think Hilary's duly noted that. I can see it looking. Dee?
Thank you, and thanks, Hilary. Again, similar to Francis, really, just something we just highlight a little bit at the Workforce Committee, but just about the sort of staff burnout risk, I suppose. I know we've got that in the paper that Lynn had put earlier in the sort of gold command risk, but I suppose the more that we understand about the pandemic and the length of time it's now likely to go on, is it does become a sort of enduring risk rather than maybe a sort of short-term risk, and maybe just asking the executives to consider how we might best capture that in the risk log. That's not to say, I know there's enormous amount going on in terms of health and well-being of staff to try and mitigate that, but as we approach a sort of second wave and that becomes more sort of enduring, it maybe starts to become a bigger issue than sort of vacancies per se.
Yeah, that's a very good point. I know we look at this obviously in silver every week and in gold every week, and we certainly review it and add to and pick that up. Michelle, I noticed your hand went up there.
I was just going to say what you've said, Hilary. We do pick this up at Gold Command Dean every Thursday, and I think one of the things we did say, probably not last week because I wasn't here, but the week before, that we just needed to probably keep risk of assessing this, because we put it in, which is why we did the work through August, why we're continuing to do all the work around having breaks, etc. But I think we probably just need to reflect it a bit more on the risk register, so we'll do that, and it will. You'll see that next time.
Thank you.
No, it's a good point, Dean, because I mean, yeah, and it might well move from a command risk to just the corporate risk, if you like, be more permanent. So absolutely, that's a good point. I think that's it for questions, but I would just say as well that obviously it's good to see the things that we're discussing and the things that are coming out in the board papers are obviously the things that are reflected in the risk register, including, for example, the reduced bed base and discussions that we had earlier.
Yeah.
So thank you for that. If we move on to then the winter plan, Lynn, this was suggested, I think, by Michelle at our last board meeting. So thank you for the paper. So over to you, Lynn.
Yes, thank you, Chair. So this the purpose of this paper obviously is to set out the approach that we're taking to winter planning this year. There's obviously, as we've already touched on, significant interdependencies between our COVID preparedness, the phase 3 planning work associated with that, and a winter. I think we've already mentioned the word challenge in relation to winter this year. I really had to refrain from overusing the word unprecedented. In fact, I kept it to once, I think, in the report today. But there's no doubt about it, the challenges that we're facing this winter are challenges we've not worked with in the same way before. For the reasons that I've already said so far this meeting, I think we're doing everything that we possibly can to prepare for that. Not only obviously in terms of COVID or coronavirus, interesting the discussion that we're just having around the ongoing nature of the pandemic. I heard it described as a chronic pandemic the other day, and I think that really is the territory that we're in. So the paper sets out obviously that we are focused on winter. Obviously key to that is the robustness of our business continuity plans. So for the reasons that we touched on earlier, we are undertaking a in-depth review of those to make sure that they are really fit. We've obviously discussed the potential of a flu outbreak along with COVID. So therefore our flu vaccine campaign this year is more important than ever. And you've already heard about some of the work that we're undertaking to address that. We have got a higher number of peer flu vaccinators than we've ever had previously by some significant margin. And our expectation is that, you know, our flu uptake should be even better than we've managed to achieve over the previous years, which has been good too. Not forgetting that we've got the EU exit to consider as well. In relation to our planning, Pete Beckwith is our SRO in relation to that, and our EPRR team are involved in that work as well as meeting the sort of national NHS expectations that certainly across all areas, but specifically the acute hospitals, that the acute hospitals remain and maintain, restore the elective activity along with the COVID activity. And that message obviously goes not just for the acutes, but for our services too. So that's very much sort of the emphasis of our planning for this year. Obviously the usual arrangements are in place, but obviously even probably more stringent around the stress testing. And you've already mentioned, Sharon, that some of that's been done already around our COVID plans. But at the moment, obviously a number of system events taking place to make sure both the COVID and the winter plans are resilient and are robust. So I'll pause there. The paper obviously does go into some detail around some of the individual service areas, including touching back on the mental health acute care pathway and the out of area bed position and actions that we're taking there. But I'll pause.
Thank you, Lynn. Really important paper. Dean?
Yeah, thanks, Lynn.
Have we lost Dean, or is it just me? Dean, we can't hear you, sorry.
Can you hear me?
Oh, you can hear you now, yes, I think.
Yeah. I was just saying, just thanks very much, Lynn, for the comprehensive update and acknowledging that I guess for the whole of the NHS as it goes into this winter is going to be more significant than any other that we've experienced with all those things that you've highlighted. So not just flu, not just COVID, you know, Brexit and all the other sorts of things that we might sort of anticipate. And just checking, Lynn, you mentioned the point about the sort of expectation maybe as we go into a second wave of trying to retain as much activity as possible rather than last time round when we were trying to reduce activity to concentrate on COVID. And just that maybe that approach to mutual aid in a system and a system escalation approach and our role in that, and you know how that sort of sort of plays out, I suppose, differently this year because of all those other issues.
Yeah, I think the really good points, Dean. I think the system approach actually is understood across the systems that we're working in at the moment. So if I take North Yorkshire and York as an example, obviously where our physical community services are, obviously the work that we're doing along with the acute hospitals, particularly around discharge, again, which is why I referenced that particularly in the paper. We're expecting obviously that the pressures activity will rise across our community services. And I guess already we're hearing sort of primary care in North Yorkshire is already under some pressures in terms of activity. We're seeing that, we're feeling that pressure in our community services right now. Now, what we do have in place, I think, is the mechanisms around that sort of mutual aid We've already got the emergency planning. There's a gold command that meets every week in North Yorkshire at the moment. I did that for Michelle last week, for example. So certainly those conversations are happening around sort of touching on where are those pressures actually starting to materialise, and what are our plans and how robust are they. We've just submitted a quite detailed winter plan to North Yorkshire as well around the impact for our community services. So underneath this sort of high level paper, there are more detailed plans supporting all of our service areas, and we're playing those plans in as we need to. For the reasons that you've said, I don't think we can belie the pressures that we're anticipating. It is unprecedented, but again, I think the system arrangements are working as well as they can do, Dean, around this area.
Thanks very much, Lynn.
Thanks, Lynn. Michelle, and before I take the other questions, do you want to come in on that point?
Yeah, I think just to reiterate what Lynn said earlier, I think one of the things that we really learned and we developed from the first wave was the system working and working together, and obviously that's being maintained actually. All right, some things have been stood down a little bit or just eased off, and now we're actually just increasing those. For example, the Gold Command at North Yorkshire went to 2 weekly, now it's come back up to 1 weekly, and same for the national calls as well. So I think there's still that understanding that we do need to work across the patch. We just had a big mental health, particularly mental health focused regional, building on the work that we did locally, regionally, because I do sometimes, if we're planning on a really bad winter, which we are, I think there's going to be some cross ICS work anyway. So I don't just think it's on the local systems that we've got, the North Yorkshire and York, the Humber system. I think it's the general, how we work as a whole North of England work. So we've actually started to do some work, certainly from a mental health point of view, with the other ICSs as well. For example, secure forensic beds. How, if we're going to get access to those, what's the best way to do it? Forensic access to staff, etc. So I think we're trying our best to plan for as much as we can, but who knows? I mean, this is uncharted territory. But our figures and the demand planning that we've done. We've always kept services open, but one of the things that the NHS is doing at the moment is not standing down any services at all like they did in the first wave. So we'll just keep going, and obviously it will be compounded by local lockdowns as well, because on top of that we've got the local lockdowns to contend with as well. So, but most of that is being system planned as we speak, and I think because we've got seats on the outbreak boards as well, I think that's really helpful because not everybody has. But we do, and I think that really helps us just have that little bit of heads up about where the figures are going and where we're going and how we can react to that. I don't want to emphasise Brexit as well in there. I think we sometimes concentrate on flu and what have you really got to start. And I think we as an organisation need to understand a bit more detail about the ramifications of Brexit in the plans. And obviously we're starting to do that as a system as well.
Thank you, Michelle. It's really helpful. Francis?
Thanks, Chair. I think between them, Michelle and Lynn have answered most of my points, but I was just going to reiterate the point I made earlier about worst case scenario. I don't think any business in the UK had planned for a complete stop of their income streams overnight, and have really struggled as a result of that. So it's the same here in effect. You know, if Michelle's right, what happens if we've got lorries queuing up on the M62 into Hull? If there's no out of area beds to put anybody into, if it then freezes and there's snow and ice everywhere, I don't want to be Mr. Doom and Gloom, but people just don't really think about what is the absolute worst thing that could happen, and have we got a plan just in case for that. So it's just an encouragement that what Michelle's talked about is done at the whole ICS level, because we just don't know what is coming basically, and hopefully there'll be an upside, but it's always better to have the plan for the worst case scenario.
As my team will say there, Francis, I always plan for the worst possible scenario that you can possibly do. And then at least if that doesn't happen, it's great. But at least we've got that and we can work back. And that's why some of them are smiling now, because we are planning almost for that Armageddon doomsday scenario. And if it doesn't happen, that's great, but we've got a plan. And we're trying to work with the ICS to develop that as well.
Thanks for that. John, is it on this point?
It is.
Yeah, go ahead.
So Sharon, it just refers back to the military planning that took place with within the ICS a couple of months ago. Those of us from a military planning background will tell you that no plan survives first contact with the enemy. And irrespective of whatever plan we come up with, Francis, irrespective of how clever it is, how much work has gone into it, I think what we're going to need over the winter is strong leadership and management and the ability to innovate and think on our feet, because I'm not really sure we can really predict what the worst case scenario is, even with the best efforts of the pessimistic merchants, is what I would say. And I don't want to set us up to fail to say, well, why didn't you predict that? Because I think what we've learned from the epidemic or the pandemic is some things we just couldn't have predicted, perhaps at an earlier stage.
No, John,
I don't think that reassures you, but
I agree with you, John. Leadership and flexibility will be absolutely crucial as we go into it.
Okay, thank you for that, John. Peter Barron, you've been waiting very patiently.
Oh, thanks, John. It's only a quick question, really, because in here, obviously beds are at a premium, aren't they? And in here we mentioned about the Inspire unit, and I just wanted at some point either now or to the later date to know where we are with increasing the capacity of the Inspire unit to full capacity and open the PQ unit on top. So I guess the surge is going to come. It's going to come because it's winter, but it's also going to come through perhaps increased referrals and increased instances of CAMS type arrangements and difficulties for the younger age groups. So I just wondered really at some point if we could have an update as where we are on getting that to 100%.
Lynn, are you happy to circulate that outside the board?
Yeah, if I just let you know where we are with that. So we are reviewing that continuously. We have been, Hilary and I have actually got a meeting, I think it's this week, to meet with the service again. Following that conversation this week, we will be making a recommendation to Michelle and EMT around the date to open PQ. So as soon as that happens, then obviously we can share that with the board.
Thank you, that would be helpful. Thanks, Peter. So I think that's it for questions. So thanks again for the paper, Lynn, and all the discussions to everybody. We are, at Michelle's suggestion, we're having a session with the governors at the next development day for the governors on winter planning. Adrian Ellsworth's going to lead that. So I think that'll be really useful for the governors as well. So thank you very much for that. If we can move on to then item 26, which is manager ligature and other risks. Lynn, I think this is down for you as well.
It is, yes. So again, I hope the paper is relatively self-explanatory, but just to be brief about it. So this is some further briefing guidance that has been circulated to trusts by Kevin Cleary, Deputy Chief Inspector from the CQC, specifically in relation to ligature anchor points. And the key issues that he's raised in that briefing is that he commends trusts for actually making very good progress with addressing ligature anchor points over recent years. However, he remains concerned that some trusts continue to have some high-level ligature anchor points that have been on their risk registers for some time without being mitigated completely. So he's raising this issue with all trusts that they really need to be focused on this and addressing it. The other issue that he raises particularly is that some low-level ligature anchor points, or anchor points that have been considered as low-level in the past, actually from evidence do pose risks. So he's asking trusts to review that position around low-level anchor points and address those too. So from our point of view, we have continued actually to undertake our ligature anchor point risk assessments, and in line with our current policy. Also, we have been quite focused on that through the COVID period too, particularly where we've been changing the use of our inpatient wards and the patient groups within them. However, we are assessing again that those ligature anchor point risk assessments have completely encompassed the points that Kevin Cleary has particularly made. Those ligature anchor point risk assessments will obviously then come through the governance process very shortly to ensure that they are robust. The other element that Kevin Cleary is raising too is that particularly non-exec directors have oversight of the ligature anchor point work. So from our point of view, the the annual ligature anchor point reports will come to next quality committee, and it will also be on the agenda for the Finance and Investment Committee from the capital programme perspective. Also, we've obviously looked at this as well through Hillary's team. They are coordinating the CQC peer review process that you've heard about before, and these ligature anchor points requirements are being incorporated into that peer review process, just to give us that assurance that, you know, not only are we seeing it in the assessments, that through the peer review process we can ensure that staff are fully aware of these issues as they should be.
Thanks, Lynn. That's great. So we've noted that the report will go to the Quality and the Finance and Investment Committee respectively, and that's really good. And I'm sure their assurance reports will then report back to the board that they've done that, to close the board circle on that. Any questions for Lynn on that paper? No, I think that was pretty comprehensive, and you've got a plan of what you're doing, so thank you very much for that. So if we can move on to item 27, which is the board quality improvement project. And I'll probably bring Jenny in here because Jenny's done most of the work, in fact, nearly all the work, to be fair. This was, if you remember, set quite some time ago, and apologies for the fact it's taken so long to come back to the board. It has grown in as a project. John did warn us that this might be the case. It seemed a quite straightforward sort of look and task when we started. It was John's challenge to the board that we should show willing and do a quality improvement initiative. And I have to say, it has grown, and that's one of the reasons for the delay in it coming back, and it has been really useful. So you've got the report there. Jenny, to be fair, you've done an enormous amount of work on this. Is there anything you'd like to say about the project? I'm putting you on the spot now, but you have done an awful lot of work.
I mean, most of the updates are in the paper, so it shows what went well and what didn't go well. It did, as we anticipated it would, the work did increase, and we did check against all the other work plans for all the different committees. But the main bit that was really sort of important and well, helpful was looking at the agendas and getting the papers in, and actually using a reg rating system on the agendas to actually monitor when the papers came in, when they came in on time, and that was increasingly useful during the COVID-19 when we didn't have paper versions to sort of tick off or anything like that. So I did find that very useful. But it was very rewarding doing it. It was a lot of work, and has taken some time to get there, but I think we've got the outcomes that we wanted.
Thanks, Jenny. I think so, and I think I have to say, in governance terms, I think it's really strengthened what we've done, and I think things like even the board work plan, and you've been notified about what's missing and why, and even the non-exec roles, and that was one I added, that you know, we asked for a non-exec lead on this, and then 3 years later nobody can remember why or where it came from. And that's not, you know, that's not sort of tight governance. So I thank Jenny and Michelle Hughes, who isn't here, but for her part in it as well. It has been a worthwhile project. It has been a lot of work, particularly for Jenny. But as you anticipated, John, it did somewhat escalate from the original brief. But I think it has been very worthwhile. So thank you to both of them. John.
So firstly, Sharon, fair dues to you and Jenny and Michelle for taking on a project and actually bringing it back to board. And actually, I think the most important messages are quality improvement isn't easy. It's actually quite hard. And the first mistake we tend to make is biting off that more than we can chew, and then understanding what good looks like in terms of data and stuff. So, you know, having done this yourself, I think in terms of quality improvement in the trust, we're well over 100 projects now underway through the QI team. And it's fun to play and experiment with this stuff, but actually if you get it right, you can improve the quality impact, whether it's a corporate governance, whether it's clinical governance, or more importantly, patient and staff experience. So we are now doing this across the trust. It is growing incrementally and organically. And thank you to you for picking this up and bringing it back to us. I might actually propose that you become the poster girl for quality improvement at board level on a national level, and you can tell your story more widely.
Happy to talk about it, but to be quite honest, John, I tended to come up with I think it's called, is it called creep, Jenny? Scope creep or something? I just kept coming up with other ideas for Jenny, but I can't take the credit really because Jenny predominantly did all of the work. Michelle?
Yeah, I suppose building on what John said earlier, I think it's really good that, and thanks Jenny and Michelle, and it's really good that you feel you got something out of it. But I do think, and this is maybe for Adam, that we probably do need to do a bigger piece, whether it's on board talk or just for the organisation, because staff are doing this across the organisation. I think it'd be really good for them to know that the chair and the board have undertaken a piece of work as well. Because sometimes I just think that we're just concentrating on their area. So I think we just need to think about how we can communicate it, whether it's in board talk or whether we do a little bit of something separate. But I'll leave that to the Adam and the comms team. But I do think it warrants that a bit of a higher profile, really. But good, I'm glad you enjoyed it. And mission creeps we've always got to avoid the creep piece. But well done on getting there in the end.
Thank you, and yeah, I do agree. I think it's very important that we share it. So yeah, good point, Michelle. So Adam, can we pick that up, please, with Jenny and probably Kath as well, who's been, I have to say, John, been really helpful throughout it, checking in with us and been very supportive of the process. But yes, it has been a worthwhile process and it's been a learning process. But I think we genuinely have come out of it in it has been a useful process, not just time consuming. So yeah, it was a good challenge to set us, John, and I think it has been worthwhile. So thank you for that. Next one is items for escalation. I don't think there are any, unless anybody's got any. No. Any other business? No. And there's just one thing I should have mentioned actually in my report, which I didn't, was just about the preceptorship celebration that I attended, that Hilary and John also attended, I think, to celebrate the new training and the achievements if everybody's gone through it and the change to the training programme. Hilary, I think it would be worthwhile if we could just send at least a video and maybe some information around the other non-execs, because fantastic piece of work that's having amazing results. And I mean, the people who are involved it was just amazing. I was blown away with what they've achieved. So I think we should just, if it's all right with you, just share it around the other non-execs who won't have seen it. It seems a shame not to celebrate it. So apologies for not mentioning that earlier, but fantastic event and fantastic piece of work.
Thank you. Yeah, I'll send it round. I say it's the shift from the preceptorship, the newly qualified clinicians we've gone to an academy, which has obviously got higher level education in there, and it can be bespoke to them so they can pick the modules and things they want. But the thing that really makes it different is the fact that it's multidisciplinary. Often preceptorship programs for the newly qualified focus on nurses, but we've got everybody in there, so it really does demonstrate that multidisciplinary working and learning and education and peer support all in that academy approach. So I thought it was a really good event, and it really showcased what the team had done. So I will send it round after the board.
Thank you. John?
I just want to compliment Hilary and the team on it. The anecdotal feedback I get from some of the people who've been on the programme is absolutely fantastic. And actually, I think it's really important that we shine a light on this development work that we're doing, particularly with our nursing colleagues, because I know the medical directors are good at championing the stuff we do around the medics, but actually a brilliant piece of work, Hilary, that your team are doing.
Thank you. I'll pass that on to them.
Thanks, John. So just to reiterate, we'll now close the meeting in public, but any comments or questions that have come in via the YouTube streaming, we will respond to separately. So thank you everybody for joining us, who's joined us on the live stream. Thank you to board members. So if we could stop streaming now, Adam, please.